our folks trickle in. Tonight, we're going to get into some of chapter 2 here, which is really workforce safety and wellness, as well as some transport operation stuff. I don't envision it taking 4 hours, but in that vein, and I said this last Wednesday, help me to help you folks get out of here on time. So, if I throw out a question or if I call on you, please come off mute or go ahead and throw it in the chat box, just so I know people are paying attention. I also am probably one of the few virtual instructors that encourages folks to actually turn their webcam on. So if you want to do that and be a part of the class, feel free to do so. Otherwise, feel free to hide out in the background. So. How did Saturday go for folks? That was your first skill session?
I liked it.
Okay. I thought it was fantastic.
It was very helpful to
Good.
do more hands-on because that's how I learn better is hands-on. So it was very, very helpful.
Absolutely. And for those in Concord, of course, I was your favorite instructor there, right?
Yes,
absolutely.
Yep.
Good. Bonus points all around.
Wait, who else is on the call? No.
Yeah, easy now. All right. So
are we going to
go
discuss are we going to talk about potential impact for Saturday?
Yes. So let's go ahead and get going here. So thank you very much for coming back. I wasn't sure that most of you would come back after last Wednesday and Friday, so I'm happy to see you all here. Again, my name is Dave Muse. I'll be your primary instructor for tonight, and we're going to be going through Chapter 2, Workforce Safety and Wellness, and Chapter, I believe it's 19, Transport Operations. Before we get to the content of tonight's course, though, I did want to take a moment to address some of the lingering questions about class on Saturday. The only news I have for you folks is that a determination will be made by Friday night's class as to whether or not class will happen on Saturday or not. I want to caveat that comment by saying, we're all adult learners here, and, use your discretion as you're driving to the site. So even if we do host class on Saturday, your safety is our number one priority. So if, you can't even get out of your driveway, or if you're driving and it's not safe for whatever reason, feel free to turn around and go home, and we'll come up with alternative accommodations or arrangements for you. So that's the only update I have on Saturday. Does anybody else have any thoughts or questions about any of the other content or anything that we've covered? Observations so far?
On Saturday, what are we going over?
Great question. I think on Saturday, I don't have the guide in front of me. If I'm not mistaken, it's high performance CPR. As well as, give me a second here.
Is it splinting?
It is high quality CPR, airway management skills, and the secondary assessment to your patient assessment. So what I noticed from a lot of folks in Concord was that you folks wanted to take your patient assessments a few steps further and start getting into things like sample history and vital signs and all that really important stuff. And we'll address that on Saturday as long as we have class. And, we'll build up the second half of your patient assessment. We just wanted to provide you folks with a foundation and a framework of, doing an initial scene size up, making sure your PPE was appropriate, and then really addressing the ABC concern, the airway, breathing, and circulation prior to getting into the secondary assessment component. So again, on Saturday, as long as we have class, we'll dive into the secondary assessment, high performance CPR, and some airway management skills. Great question.
I did figure something else out too. I know my group, some of us were having a hard time with the blood pressure hearing the heartbeat in the stethoscope. And I found out that we were using hard tips, and that was my problem. So a soft tip stethoscope really did the trick. So for those that were also having problems hearing it, that could very well be the problem.
Interesting. Okay. Thank you for sharing that, Melissa. The other thing a lot of times, and we'll talk about this when we get more into stethoscopes and taking vital signs, blood pressures and whatnot, is a lot of times the bell, which is the endmost portion on the stethoscope where you put it against the patient's skin, that bell can be twisted on some of them and actually switch over the side in which you would use to listen. So if you have the bell improperly turned, you're not going to hear as well as you would if it was flipped in the opposite direction. So, but we'll get into that when we start putting some hands-on stethoscopes and actually sinking our teeth into the vital signs. So Awesome. Other questions or thoughts before we get rocking and rolling here? All right. So I just had to ask, I have to ask the question, what did the paramedic say to the badly injured Power Ranger? What did the paramedic say to the badly injured Power Ranger? It's morphine time. All right. So moving on. So tonight, again, we're going to dive into chapter 2 here. We'll start off with chapter 2, which is our workforce safety and wellness. And I want to preface this chapter by saying to you folks that really, at the end of the day, do no harm is the foundation of everything that we do. And that means do no harm to the patients, but also do no harm to ourselves and others. So really the foundation of this chapter here is making sure that you're looking out for the wellness of yourself, the wellness of your partner, and then the wellness of your patient. So without giving too much away, that's what we're going to go through. The competencies we're going to talk about, obviously using simple knowledge of EMS systems, as well as the safety and well-being of our EMR. We'll also talk about a little bit medical and legal issues at the scene of an emergency. And this is sometimes in the course where a lot of questions, kind of the what if theory comes into town, and they're like, well, what if this or what if that? If we start to go down that pathway, I certainly encourage folks to ask questions, but if we get too far off the rails tonight, I'm going to just bring it back and say, hey, that's kind of outside the scope of what this course is about. And what I'll say is in a lot of those situations, the what if, it's going to be predicated on a multitude of different factors and kind of the totality of the circumstances. So there is no one size fits all answer in a lot of these kind of legal situations and scenarios that we might get into discussing tonight. So that's my disclaimer. I'm also not a lawyer. I'm just a bad comedian. So I'm not going to pretend to know the law, but I know enough about EMS law to actually teach this. So a couple other things we'll review tonight, standard safety precautions, PPE, personal protective equipment. Everybody after Saturday should hopefully be really familiar with that because it's one of the core components of your patient assessment, right? We'll also talk a little bit about stress management, healthy ways to deal with stress, unhealthy ways to deal with stress. We'll talk about death and dying. And unfortunately, hopefully everybody in this course is aware, as an EMR, death and dying is something that you folks will unfortunately likely experience. And you need to know how to navigate death and dying, both on a personal level as well as on a level of taking care of your crew, but addressing the family of the deceased on scene. And I know some of you folks have already been in the field or continue to work in the field. So perhaps this is an area that many of you have already been exposed to, but we'll talk about that a little bit more tonight and some things that I've found helpful over the years without going into like war stories and stuff like that. And then we're going to talk about prevention of response-related injuries. So medicine, of course, when we're talking about medicine, we're talking about, how to manage the most appropriate life threats based on whatever our assessment findings are. So at the end of the day, we get in there, we make sure our scene's, safe. We make sure we've got our PPE on. We need to do an assessment in order to figure out what type of medicine we're going to perform to treat. So we'll talk a little bit more about that later, right? We want to make sure we're giving the right treatment and medicine to the right patient for the right reason at the right time. And of course, a term I know none of you are familiar with, infectious diseases. Living in the proverbial COVID hell, as we've been calling it the past, 2.5 years. We'll talk a little bit more about working with patients that have infectious diseases and how to properly decontaminate equipment after treating and transporting a patient. All in the span of what I hope to be about an hour and a half. So, introduction. You, your patients, and their families obviously can experience various degrees of stress and grief as you folks get out there in the field. Anytime you're on the scene of an emergency, or even when you're off scene of an emergency, right? So, to fulfill your duties as an EMR, you need to be in good physical condition. Being in good physical condition isn't necessarily meaning that you're a marathon runner and you can do all these crazy lifting and moving things. But at the end of the day, EMS is a physical sport. It's also a team sport. So you need to know how to properly lift and move with your partner, and hopefully lifting and moving is something you folks covered on Saturday, and you get some of those dynamics and body mechanics down. But you need to be in good enough condition to help support lifting and moving these patients. And you need to know, more importantly, when to. Don't want you folks blowing out your backs or injuring yourselves either. One of the worst things you could do as an EMS provider is actually drop a patient. So knock on wood, it hasn't happened to me yet. But I've worked with people that it has happened to, and it's not good for anyone. A lot of departments require some type of physical examination, not like a physical fitness test or anything like that, but just a clear from your doctor or healthcare provider to make sure you're healthy enough to do your job. So your departments and your organizations will run you through whatever process it is prior to hopefully you getting on the job. And it's really important that you folks actually take the time to disclose any medical or other conditions you have to your employer during that onboarding process, because, you know, hopefully you can come to an agreement and they can make some type of special accommodations or arrangements with you to keep you safe as well as the patient. Shifting gears a little bit, talking about some of the emotional aspects of emergency medical care. You know, how to avoid unnecessary stress and how to prevent your stress level from getting too high. What I'll say about this, folks, is that you're the licensed professional on scene, and how you compose yourself will set the tone for bystanders. It'll set the tone for the patient. And a lot of times it'll actually set the tone for other responders that are on scene. So if you're getting there and you're running around like a chicken with your head cut off and you're all frantic or whatever, A, that doesn't portray you as a professional, and B, that actually amps up people's adrenaline and whatnot, which, you know, isn't really beneficial. And anybody that's actually worked in like public safety before, or some of you folks that are on departments right now, and I'm not making fun of dispatch because I love dispatch, but we all know those dispatchers that get excited for us, and they'll dispatch a call and their voice will be super high and all, you know, like 36 octaves, like higher. If the dispatcher is super excited and like trying to put out a call over the radio, the tone and the inflection in their voice can actually indirectly set the stage and the tone for the other providers that are responding. Because if my dispatcher's amped up, I'm probably going to get amped up. Then the patient's going to get amped up. It's just, nobody wants to get amped up. So, you know, like Gandhi said, be the change you want to see in the world. I'd say be the calm EMS provider you would want treating yourself or your family members. So some of the most stressful calls include patients that remind you of a close family member. And not going to dive too much into war stories here. However, what I will say is that depending on where you're at in your life and different things that you have or currently are experiencing, you may be affected differently from working with or treating specific patients. And probably one of the most horrific examples I can give to illustrate this point. One night, a fellow provider went out to a car rollover, and it was a fatality of some younger pediatric patients. And she was a newer mother. And to have seen that and to go through that call and deal with that emotional turmoil and everything else, she did the call, and she was a trooper on the call, but she came back and she turned in her badge and her radio and everything. And she totally washed her hands of it. And, you know, that's kind of an extreme example, but this stuff happens. If you're a parent, if you, you know, have a recent death of a family member, or even like 2 years down the line, my grandfather passed a couple years back, and I vividly remember maybe a year after treating a patient who reminded me, his mannerisms, his looks, everything about him just really screamed the demeanor of my grandfather. And, you know, if I'm being truthful and honest with you folks, it bothered me. I mean, that call bothered me more so than some of the other calls I've ever been on, where I've seen and dealt with blood, guts, gore, and everything else. But you have to be cognizant of it, and you have to realize kind of what your limits are, and you have to set those boundaries for yourself. I also said earlier, EMS is a team sport. So at the end of the day, If there's a call that you're dealing with or having a hard time with, or a patient that you're just like, this person reminds me of somebody that just passed or whatever, tag someone else in. Have your partner just say, hey, I need to step away, or can I drive on this call or whatever. You don't need to disclose all the information right then and there, but lean on your partner and know when your partners are trying to lean on you to step in as well. So for some reason, we also have a really very hard time with super young patients. Like anytime a call involves a pediatric or a child patient, people get really excited and are really sensitive to it. And also sometimes on the opposite end of the spectrum, really old patients. If you're in EMS for any length of time, I guarantee you one of your greatest fears will turn into aging because of some of the horrific things that we see and we deal with that regarding geriatric or elderly patients in the elderly population from falls and conditions in which they live in from time to time. So critical patients and of course, death of patients on scene all can have impacts as well. I'll tell you again, for those that haven't been involved in emergency services, a lot of people have grabbed onto unhealthy coping mechanisms by having kind of that dark EMS humor. And what I'll say about that is just know your audience. If you're one of those folks that, tends to laugh things off or makes jokes or comments or whatever, make sure you're out of earshot, not even on scene. Don't be doing that stuff on scene. But when you get back to the station or whatever, or whatever, don't be alarmed if other first responders make jokes or whatever. Laughter is a coping mechanism for some folks. But just keep in mind your audience. And obviously, if you're uncomfortable with it or you think somebody else is uncomfortable with it, call them out on it and try to put a stop to it. There's a time and place for it. And that's all I'll say about that. So emotional aspects of emergency medical care, of course, some more stressful calls here, calls that have unusual danger associated with it. And a lot of times, well, hopefully you're thinking about the danger that you're putting yourself in on scene. Like if you're on the side of a highway, the traffic that's going by, if you're, staging close by to extricate a burn victim from a house, and you're close to the source of the flames and heat, you will be in situations that, the average everyday person doesn't define as necessarily the safest. And sometimes those dangerous situations can trigger additional stress, maybe not in the moment, but later on. So just think about that. Episodes of violence. So for whatever reason, and I'm not going to get into the psychology and sociology behind why violence really unearths and unsettles people. But whenever somebody perpetuates an act of violence against another person, that can be a real trigger or additional stressor for folks. And a lot of times what we find is our providers and our folks want to try to understand the why. Why did this happen? Why did this happen to this person? You might have to deal with family members of victims, stabbing, shootings, whatever, fatal DUIs, whatever it is. Why did this happen to me? And we'll talk about DABDA and some of the kind of process of grieving a little bit later tonight here. But at the end of the day, anytime an episode of violence is perpetuated, it's definitely a heightened stress level. Things like unusual sights, smells, or sounds. What I will say, and I'm again not going to get into the nuances of like PTSD, post-traumatic stress disorder, and stuff like that. If you go on super stressful calls or calls that stick with you, certain aspects of those calls could very well stick with you. Things that you saw, things that you smelled, or specific sounds can definitely stress us out and put us on edge. They say smell is the sense, one of the senses or the most prominent sense that links back to memory. So if you smell something, sometimes it'll trigger memories like the smell of blood or whatever. And then, of course, mass casualties. Hopefully nobody here has to deal with any mass casualty or MCI incidents or situations, but these can really stick with people as well. And, any of these situations that we've talked through can definitely produce a higher level of stress, not just for the patient, but for you. So in the vein of emotional kind of care, and because you folks work in a stressful environment, you really need to make a conscientious effort to prevent and reduce unnecessary stress. Now, I'm not saying that you divorce your significant other, or you go tell your boss off, or you quit your job, your full-time job or whatever. But doing these simple things can really help you in the long run. So the first thing is learning to recognize the signs and symptoms of stress. And what's important to note about this is stress manufactures itself or presents itself in different ways in each and every one of us. So, know what your stressors are and what your associated signs and symptoms for those are, and just be mindful of that. Also, if you're on a rescue squad or have a regularly scheduled partner, it's really good to have an upfront and honest conversation with them about what are their stressors, so that you can maybe kind of keep an eye out for their stressors as well, and work to help each other mitigate some of those along the way. And this way you also know what you're looking out for in your partner, EMS partner, that is. So adjust your lifestyle to include stress reducing activities. Wouldn't it be great if we could all do yoga and do, the 3 hours of exercise a day that they recommend and everything else? But my emergency management job, I was just on the computer for like 9 hours, and then I'm teaching tonight from 6 to 10. I took a walk in between, and I had to just get out of my house and get some fresh air. That was really relaxing for me, and that works. So anything that you can do in your lifestyle to get up and get active and get moving, or even just go outside, or do whatever it is that helps unwind you, go for it. And then finally, learn which services and resources are available to help you. What I'd say in this regard is the suicide rate in first responders is like skyrocketed. And I think it's for a variety of reasons. But the one silver lining to the increase in suicides and mental health issues amongst emergency responders or first responders is that there are now more resources out there than ever. You just have to know what those resources are, and your supervisors, your department leadership, they can put you in touch with those groups. Most companies or organizations have an employee assistance program. There are tons and tons and tons of resources out there available to help you. And even if you don't need it, it's good to know what they are so that you can refer friends or other EMS providers, your partners, to those resources as well. So also disclaimer, this is some heavy stuff we're talking about tonight. So if this triggers bad thoughts or feelings or whatever amongst any of you, and you're having a hard time with any of this, feel free to drop off and just reach out later on, and we'll get you caught up or whatever. Questions on any of this heavy stuff? So I want to hear from you.
I would probably take everything that
ahead,
he's saying quite seriously, and I'm only saying this from like experience with a lot of my friends that I've had in the military and those that I know in EMS and all, especially for all of y'all that are really young. I mean, it's quite a serious job that not a lot of people in this country are doing, and let alone the military. I mean, I have my own experience on that, but just working on the streets in your communities, you'll have a week of absolutely nothing going on, and then suddenly you're going to be at a car accident and you're going to see, a 4-month infant in the middle of the road. And sometimes that's going to get to your head, and you need to not be afraid to like talk to people about it, because, everybody you work with, you're a team. And if you're that kind of person where someone's going to have to come up to you and say, hey, I have a really serious problem, and you ignore that, then this isn't the job for you. Everyone has to work together. It's, it's just, I think it's just, I forgot what the, I was reading an article about it recently that it was on, I forgot which website, but they were talking about just what, firefighters in New York City, go through time to time now. And the suicide rate was at its highest in 2020, just for New York City alone, which is just astonishing, so you got to really take it seriously and look out for one another. I mean, I personally have friends that have gone down that road, and, I wish I could have been there, but I have friends around the country. So take it real seriously and pay attention to your colleagues, because when you see things like that, you need to step up and take it very seriously.
Yeah, thanks for sharing that, Chris. So in the spirit of trying to pull out the positive here and shift gears a little bit, if folks want to either A, come off mute, or B, plug it into the chat window, what are some healthy ways that you folks deal with reducing stress?
My biggest thing is honestly talking. I mean,
Okay.
I've been down the road where I've kept things to myself, especially when I was really young. And I've been through some pretty stressful situations in my lifetime, especially in my military career. I kept it all to myself. As I grew older and more mature in that career field, I learned that, really getting along with your colleagues and, you guys to your side, that's a huge factor.
Yeah, thanks for that, Chris. Yeah, awesome. So some other things, Morgan says running, Brian says exercise and talking with friends. William says fly fishing and fly tying. I'm not sure what fly tying is, but that sounds pretty awesome. Exercise and talking to close friends, going for long walks, walking, coloring. Oh, Aaron, that's a good one. I actually have a coloring book in my desk. Wait. I'll deny I ever showed this to you folks, but somebody bought me a coloring book. It's an adult coloring book. But anyway, it's
where can I buy that?
yes.
I have 2 of those.
Okay. So anyway, that never happened. But yes, coloring is a great example. Driving and listening to music, getting out in the woods, weightlifting, nice. So yeah, you folks, you know what works for you, right? The hardest thing, folks, is making time to actually do it, because you all have families, you all have probably very active lives. You're doing this to bridge the gap in your community, and I just don't want to see people burn out. And that's really one of the biggest things here is mitigating your fatigue and burnout, making sure you're looking out for yourselves and each other. This slide is not really titled properly. This is more of the 5 stages of death and dying and how people react to it. And if anybody's ever taken like a psychology course before, this is known as DABDA. And I would bet money that you might see questions like this again, if not on your weekly quiz, then maybe on a final or something like that, or your national registry test, about the steps that people transgress or go through when they are processing death and dying. So as human beings, it's fundamentally accepted, or one of the theories on coping with death and dying is that people move through these 5 stages: denial, anger, bargaining, and then on the next slide, it's depression and acceptance. So really, when we're talking about denial, the person's experiencing denial and they can't really recognize or believe what's happening. So if, somebody's involved in a motor vehicle accident and it's a fatality, maybe one of the passengers is okay, but maybe the driver's dead. When you first tell the driver, hey, unfortunately, or when you tell the passenger, hey, the driver's deceased, we've done everything that we can to help them. Unfortunately, our efforts were not successful, and this person is deceased and no longer with us in that regard. And the person turns around and says, no, like that can't be, like, I can't believe this is happening, or, like they're alive. I saw him breathing, or whatever it is. They deny that the person's even deceased at that point. The second stage is anger, and anger is really a very normal reaction to stress, and sometimes can be directed at you, or it could be directed at other family members. I've seen it before. If we've gone on scene and we've given CPR and we've worked them for 20, 30 minutes, and then we go and deliver the news to the family that the person's not viable, and we're we're discontinuing our CPR efforts. One family member might turn to another and say, well, if you would have called sooner, or I told you they needed to go to the hospital, and get very angry with each other or angry to you. And what I'd say is anytime you're doing some of these like death notifications, you always have to have another person in the room with you, another EMS provider or first responder. And ideally you want to have a law enforcement officer there as well, because sometimes people do get physical, even if it's not directed at you, smashing things, punching walls. I've unfortunately seen it all. So bargaining, as they move into the bargaining phase, they try to make a deal to either postpone or prolong the death and dying. So, oh God, if you don't take him from me, I'm going to go to church, or I'll do 50 Hail Marys, or, please, I'll give you money to bring him to the hospital, or whatever it is. They can try to bargain to get that person back and prolong their life. And then the other two steps, really depression. The patient or family member is usually silent or seems to retreat into his or her own world. You all know what depression is and how it manifests in people and whatnot. And then the final stage in this process is acceptance. Acceptance does not mean that they're satisfied with the situation. It means that they understand that death and dying cannot be changed. This is irreversible, and pretty, they've accepted it at that point. So that is DABDA, DABDA, denial, anger, bargaining, depression, acceptance. See it, know it, learn it, love it. And this actually has helped me in dealing with personal grief and loss in my life, but also allowed me to better help other family members, because I can tell you exactly where they are in a particular, this particular phase. There is no normal, quote, time it takes from one person to move from one stage to another, because each person is different. And they might jump around a little bit, but, by and large, most humans, this is the path they take to deal with and process death and grieving and dying. Grim stuff, very grim. Thoughts or questions on DABDA? Hopefully you've all seen that before. So recognizing stress, right? Warning signs to help you recognize stress: irritability, inability to concentrate, change in normal disposition, difficulty in sleeping or nightmares, anxiety, indecisiveness, guilt, any combination of these things, right? Once you folks identify some of these in yourself or in your partner, hopefully I keep saying partner, it's your EMS partner or your EMS crew, right? Not your significant other, but, or I guess in some instances, maybe your significant other. But once you identify and learn to identify these, how you recognize stress in yourself and other people, then you can start to help actually taking care of them. Other warning signs might include loss of appetite or overeating, loss of interest in sexual relations, loss of interest in work, isolations, feelings of hopelessness, alcohol or drugs, misuse or abuse, and or physical symptoms. So any combination of these in ourselves or others, we definitely want to be concerned, and we want to try to address whatever issues it is that we're facing. I'm seeing something about a serial killer coloring book. Interesting. Okay, I'm gonna have to get more on that later. Stress management, preventing stress, eat a healthy, well-balanced diet. I don't know that this is the most updated plate from the USDA. It might be. This dates back to, I think, 2017. I think they've changed it. What I'll tell you is anybody that's pursuing a career in EMS or going to work for, a Manchester, Nashua, larger, busier system, we don't take care of ourselves by and large when it comes to proper eating. And we eat super fast because we're eating in between calls and we want to enjoy all of our meal before we move on to the next call. B, we're always eating takeout because we're too lazy to pack our own lunch or pack a healthy meal. C, some of us deal with food, or deal with stress by eating. So I've seen so many overweight EMS providers, people that, a lot of their health concerns and considerations could have otherwise been managed through diet and exercise. And we really, by and large, do a poor job of that in EMS. So moving on. Here are the different food groups and their recommendations. So this dates back to 2005. So yeah, I think this has all been updated since then. The book was published in 2018. So I think this has since changed. But some of the more skinny folks I've interacted with in EMS regulate their calorie intake. They use things like calorie counters on their phones. They're constantly drinking water. They're up and moving in between calls, things to that effect. So yeah, anyway, all right, getting off my soapbox here. Preventing stress, drink, not alcohol, folks, not alcohol. Okay, it says drink, but not alcohol. We're talking about adequate amounts of fluid every day and consuming excessive caffeine, not consuming excessive caffeine and alcohol. Again, we're coffee addicts. When we're not working, we like to have adult beverages, most of us, but just don't overindulge in that. And of course, we're not drinking when we're going out on calls and stuff like that. Be merry. Learn to balance your lifestyle. If and when you're happy, a person generally is not experiencing an elevated level of stress. Therefore, it's important to learn to balance your lifestyle. Figure out what makes you happy and do it. Some providers like watching movies when they're on duty. Some people like crocheting or knitting. If you can weave some of those activities together and, kind of take a mental minute, you're doing better from a stress management standpoint. So other ways to prevent stress. So spend time with your friends and family. I don't know about you folks, but my family probably stresses me out more than not hanging out with them, but different strokes for different folks. If that works for you, then great. If it doesn't, then know what your stressors are and avoid them at all costs. Develop hobbies or activities that are not related to your job. I would venture, just from the people that I'm looking at right now on the webcam, how many of you are doing this as a hobby? Like I do it as a hobby. I do EMS as a hobby. How many? Yeah, so most of you folks are looking to do it as a hobby. Yeah, okay. Don't let this be your only hobby and don't let this totally dominate your life. Like it's important and we're happy you're here and serving your community and everything else, but don't let this become the only thing that you do. Do those other things like serial killer coloring books or baking or exercising or whatever it is. So exercise regularly, meditation or religious activities, and assistance from a mental health professional. Very high number of EMS providers actually see mental health professionals. And I think with the integration of telemedicine and telehealth that we've seen since COVID-19, I'm happy to say I think that number has even gotten even greater because of ease it is to actually schedule an appointment and connect with those providers. So those resources are out there and they exist, and things like conference calls via telephone or telemedicine via webcam or whatever, I think has increased the accessibility and availability of first responders connecting with those mental health professionals, which is a really good thing and definitely is long overdue. So reducing stress, you may benefit from the help of a mental health professional, a psychologist, somebody to talk through different issues or problems or thoughts with. Psychiatrists can obviously prescribe medications to help you with whatever your underlying disorder or issues are. Social workers, and then in some instances, specially trained clergy. Some people take solace in engaging with religious leadership in their issues, and that works for them. So if it works for you, then great, go for it. Otherwise, those other resources are out there. What those groups have in common, though, is that they are trained to listen to you in hopefully a non-judgmental way and really help you find ways to identify what the issues are and work with you to help you diminish your stress and deal with some of those challenges that you've got in front of them. The notion of a critical incident stress management team, or CISM, is not a new one. It's been around public safety for a long time. And basically, a critical incident stress management team is a group of, most of the time, they're peer responders, but they've got a background in helping to navigate some of the issues and challenges that we face in the way of mental health or behavioral health issues following a traumatic call. So for example, if your jurisdiction or your department goes to a really nasty incident, an active shooter, a mass casualty incident, something like that, sometimes they'll call in a CISM team, a critical incident stress management team, following that incident, and you and the other responders that were involved in that incident can go and talk as a group with these specially trained individuals, and talking through those incidents. I've been through probably, I don't know, a half dozen of them. It actually really does help, or at least it helps me. I can't speak for everyone, but because a lot of times what they'll do is they'll start off talking, a lot of times they'll like invite the dispatcher or whatever, and the dispatcher, they'll have them start and say, oh, well, I got the call from 911 and this is the information. I then dispatch, the police, and this is what I said to them. And then the police will pick up and say, oh, well, this is, the information I got. And then when I arrived, I saw XYZ, I called for this resource, and then the fire chief got there. So you kind of move through the incident chronologically. And a lot of times understanding what other people did on scene, other first responders, or why certain decisions were made, can really help put you at ease and other people at ease. Those CISM sessions aren't intended to be like an after action or like a fault environment of why did you do this or why didn't you do that from a fault standpoint. It's a non-judgmental zone to kind of talk through and actually allow the group to process feelings and emotions and everything that they saw and experienced through that incident. So Erin makes a really good point. She says, keep in mind that even if you don't feel you need to go to, I would imagine, a CISM session, if everyone goes, then the ones that do not need it won't stand out like a sore thumb. And Morgan also added that attending can also help your team members. So even if that's not your scene and you're like, hey, I don't want to go to one of these stress debriefings because I'm all set, I don't need it. Think about going from the standpoint of helping your peers out and showing support to them. We don't require or force anyone to go. Having said that, every single one that I've been to, every single person that was invited actually did go. So, because from that support network, it shows you're there to help. So questions on any of the CISM stuff or anything we've covered so far in the stress management arena? And they try to deploy those CISM teams within, I think, 48 to 72 hours. So, it's not like instantaneous, like where you drop off the patient and go back to the station and talk through it right then and there. They need to mobilize the team to get there and, invite the other responders to help out or to attend the session as well. So a lot of times we'll see it within 24 to 72 hours, somewhere in that window. Great. So workforce safety. As an EMR, you're going to encounter a variety of hazards at emergency scenes. And I know, at least for the Concord group, on Saturday, we talked through a lot of what some of those hazards that you might be facing and experiences might be. But really what's important is that you're able to identify and recognize what these hazards are and what steps, if any, you can take to actually minimize or mitigate the risk that they pose to you, your partners, or your patients. And I hate the way this slide ordered it, because when it comes to priorities, you're the number one priority, your partner is number two, and the patient's number three. So they really should have, anyway. Yes, moving on. Questions on any of that? So what do we know about infectious diseases? Someone want to come off mute? Somebody I haven't heard from yet tonight?
They can cause a big pandemic.
Okay. So infectious diseases can absolutely cause a pandemic. What's the difference between a pandemic and an epidemic?
Epidemic is pretty much something we're going to see seasonally. A pandemic is something that's happening in the now. Is that kind of?
So good guess. It's actually more to do with the geography around it. And Leo plugged it into the chat window here. So a pandemic is more of a global or intercontinental event that we're seeing in multiple spots across the globe. Whereas an epidemic is a more localized outbreak, maybe in one country or one specific part of a country, like the Northeast or something like that. So having said that, COVID-19 is a global pandemic because it's spread across the world, except for Africa, because they don't have it there, or they didn't think they had it there. And turns out they just weren't reporting data because they weren't measuring whether or not they had it. Anyway, so yes, pandemic, epidemic, good. So what else do we know about infectious diseases?
They're easily spread between human bodies?
Yeah, so depending on the type of disease itself, they can absolutely be very easily spread or transmitted from one person or one body to another or multiple bodies. What are some of the... Oh, go ahead. Sorry.
They can kill you?
They can kill you, absolutely. Yep. What are some of the vectors of transmission? So when we talk about how infectious diseases are transmitted, what are some of the different ways they're transmitted? Bloodborne, awesome. So through blood or other bodily fluids. Yep. Air, so they're aerosolized like coronavirus. Yeah, down to then inhaled through our respiratory system. Catherine, go ahead.
Would a small cut also be one?
Yeah, so that'd be like more of your bloodborne or bodily fluids that enter through some type of crack or crevice or cut or whatever, laceration on your arm or your patient's arm or whatever. Good. Direct contact, good. Oh, Connor got a big one. Connor got animals, right? One of the nastiest animals on the face of the earth are ticks and mosquitoes. Like those vector-borne insects can definitely transmit things like West Nile virus, or the ticks are known for Lyme disease. Those infectious diseases, absolutely, they're disgusting, and they'll kill you or really screw you up. So anyway, good. So you folks already know a lot about infectious diseases. Other infectious diseases, yes, unprotected sexual intercourse can absolutely cause, through the lens of, vaginal secretions or bodily fluids. So good. So you folks know a lot of this, so we'll breeze right through it. A lot of times, infectious diseases are transmitted through infected blood, airborne droplets that we talked about earlier, and then direct contact with infectious agents. Good. The disease-causing agents that are spread through contact with infected blood are called bloodborne pathogens. And up until coronavirus, I think on the ambulance and the EMS side of things, bloodborne pathogens were probably what we were most concerned about. And now, it's really opened a lot of people's eyes to the airborne droplets and the transmission through the respiratory system that has us concerned with a lot of things. So obviously, the more you know about these, the better you can take precautions to mitigate them and prevent transmission. Either a patient transmitting them to you, or you transmitting things to patients, because this is a two-way street, right? People can give us things as providers, but we can also indirectly give them things as well, and transmit infectious diseases to them. So things to be cognizant of. Perfect. So let's talk through some of this a little bit, and then we're going to take a break here in a couple minutes. So bloodborne pathogens. One example of a bloodborne pathogen is HIV. It's transmitted by contact with infection, blood, semen, or I mentioned earlier, vaginal secretions. Exposure to that, those fluids can take place in some of the following ways. So like, for example, the patient's blood is splashed or sprayed into your eyes, your nose, or your mouth. Or somebody said it earlier, into an open sore or cut or wound that you have on your hand or arm or whatever it is, right? You have blood from the infected patient on your hands, and then you touch your own nose, eyes, mouth, or your own sore or cut. One thing about human nature, for some reason, and we don't even think about it, we touch our faces a lot. So just be mindful in the ambulance or whenever you're on scene. Even if you have gloves on, you want to mitigate or minimize touching your face. Other examples of transmission this way, anybody that works with ALS providers might get we're starting IVs and or drawing up medications to give through needles and syringes. You can accidentally get poked or pricked by a needle that breaks your skin after it's already been in the patient. That's not a good sign. Broken glass in a motor vehicle collision you can get cut on that. It can cut through your gloves and your skin or your PPE. So, really, the possibilities are endless when it comes to actually transmitting some of this stuff. One of the, if not the most, there's two very effective ways to mitigate the spread of bloodborne pathogens. The first is to wear gloves, and the second way, believe it or not, is to wash your hands. So wear gloves and wash your hands. Other bloodborne pathogens that we're concerned about, hepatitis B is also spread by indirect contact with infected blood, but it's actually a lot more contagious than HIV and AIDS. So the chances of you getting Hep B are actually far greater than you receiving HIV or AIDS from someone. So, fun fact. All right, moving on. Talking about airborne pathogens. Of course, the big old coronavirus, the old Rona, is an airborne pathogen, that we've seen and we're dealing with. Some other airborne pathogens include tuberculosis, and it's contagious disease spread by droplets in the respiratory system. It really spread through air when an infected person coughs or sneezes. And even though a lot of people are vaccinated against TB, they have certain strains of that virus that are drug resistant. So to minimize your exposure to these types of patients, not just our TB patients, but also our COVID patients and some of these folks, obviously we want to wear the appropriate PPE. And in this instance, wearing a mask or high efficiency particulate air respirator or HEPA mask and put on, sometimes putting an oxygen mask on the patient can help mitigate the transmission and spread of these airborne pathogens. As EMS providers, the book also recommends you get a skin test for TB every year. Some other infectious diseases include influenza, also known as the flu, whooping cough, and severe acute respiratory syndrome, or SARS, are also spread through airborne droplets. Questions on airborne pathogens?
I do
Questions?
have a question.
Go ahead.
For the kids, the hand, foot, and mouth disease,
Mm-hmm.
what category would that be under?
Let me look that up on a break and get back to you.
Okay.
Hey, and by the way, speaking of looking things up and getting back to the crew I was with in Concord, total sidebar right now. The crew I was with in Concord on Saturday, one of the groups asked me if EMRs could clear spinal precautions in the field according to New Hampshire state protocol. And the answer to that question is no. You can take spinal precautions and hold C-spine, but you can't actually legally complete the assessment to say a patient does not need spinal precautions. So as EMRs, you're going to get there and you're just going to take manual stabilization of patients who you suspect may have a spinal injury or head, neck, and back injury. So total sidebar. Any questions on coronavirus? Y'all just want to go on a break, don't you? All right. Oh, there it is. Go ahead, Catherine.
All right, I'm going to be a smart aleck right now. Yeah, when is it going to leave?
It's here to stay. So embrace it. Well, I think what we're going to see is evolution. This is Dave Muse. This is not me talking as an instructor of the New Hampshire State Fire Academy or Bureau of EMS. This is Dave Muse, emergency manager, advanced EMT. Personally feel like we're going to see phases of coronavirus wax and wane throughout the years. So like we're starting to come out of what we're referring to as wave 3 right now. Hospital rates have stabilized in most of the New England states, and we're seeing a downward trend in the new percentage positivity rates as well as the number of new cases, because I think we've reached the herd immunity level through vaccine initiatives as well as people having been exposed to the Omicron variant. So all that to say, I think what we're going to see is this waxing and waning, or a huge number of influx of cases, probably seasonally, over time, very similar to what we typically see with the flu, where it kind of ebbs and flows. But that is not the opinion of the New Hampshire State Fire Academy or Bureau of EMS. That is nothing we've covered in the book. That's just my opinion. So cool.
Darn bats.
Yeah, sorry, I don't have better news for you folks. So let's go ahead and let's keep pushing through this real quick. Infectious diseases and standard precautions. So direct contact, MRSA is an infection caused by the bacterium Staphylococcus aureus. Most MRSA infections occur in healthcare settings such as hospital, dialysis centers, and nursing homes. And MRSA most commonly occurs in people with weakened immune systems. This is one of those really nasty diseases that you can get through, direct contact or transmission with people. And you want to take exceptional and extreme precautions when you're, if you're exposed to MRSA patients. Standard precaution, ladies and gentlemen, at the end of the day here, the best way we can protect ourselves is to treat all of our patients as if they were infected with some type of bloodborne pathogen. So to that end, we want to wear our gloves, we want to wash our hands, and if we're doing aerosolized procedures, like giving people duonebs or, intubating, we want to make sure we've got eye protection on, a face mask, and some type of respirator mask, like a HEPA mask or N95 type mask or whatever. We want to use the appropriate protective equipment. We also want to wear approved gloves and other approved supplies and equipment. I know when COVID started, there was the whole supply chain meltdown, and we saw this real demand for PPE and gloves and masks and stuff, but we also saw a huge increase of knockoff products that really weren't quality control and quality tested and whatnot. So really important that at the end of the day that you're, using only the best types of products that are, FDA approved and whatnot. So if you're anticipating blood, always wear a protective mask, eyewear, or face shield. Hey, look, I said wash your hands earlier. Make sure you wash your hands. The book wants me to tell you to wash your hands for at least 20 seconds with hot soap and water. Questions on washing your hands? Hey, this is actually a good little pearl of wisdom here. If you're working with ALS providers who are starting IVs or we're drawing meds and giving IM meds and whatnot through needles, don't try to recap the needle. That's a no-no. We just properly dispose of the needle in what we call a sharps container, uncapped. So don't try to recap a sharp. That's what we call needles and sharp things. We call them sharps. So anyway, All right, let's go ahead and take a break. Please be back here at 7:10. And don't forget to turn off your webcam or your audio if you're stepping away, please. Thank you. Daniel, we don't recap sharps because the probability of us actually getting stuck with them is higher than what it's worth. Plus, the storage containers that the sharps go in are specifically designed for uncapped products. So there is no need to recap them. We'll just drop them into a sharp container and be done with it. Great question. All right, I'll see you in 10 minutes.
That's the coloring book, the serial killer.
Oh, look at that. That's
Isn't
awesome.
she great?
That is weird. Thank you for that.
You're
David,
welcome.
I got to run home to get my charger real quick. I forgot it with me and I'm on 20% for my computer. So,
All right. Thanks, Melissa.
Yep. Thanks.
Hey, can you shut your camera off? Thank you. Perfect.
Hey Dave, do you
Yeah.
have like what am I trying to say? Like not a study guide, but like a example questions for the EMR registry?
Let me
Like-
get back on that one.
Yeah, like I don't know if there's like because I know like for there's obviously like EMTB prep the app and everything like that I use, but like for the EMR registry, I can't find anything that's like
I'm
actual.
gonna have to circle up with Max on that one, and he'll get back to you on Friday night, hopefully with that. And if he doesn't, feel free to ask him again.
Okay, cool.
Good question. Thanks, Chris.
Yeah.
All right, folks, let's start thinking about bringing it back here. I've got 7:10 on my watch, so we're going to jump back into it. We did have a great question come in. Anna Briggs said, is there any way for us to see everyone else in class? The simple answer to that is yes. If they turn on their webcams, you can see everyone in the class. Unfortunately, we can't force people to turn on their webcams, but we strongly encourage it. So jumping back in. Oh, actually, before we jump in, somebody had a question about hand, foot, and mouth disease and how that is transmitted. So according to the US CDC, Centers for Disease Control, if you don't know what the CDC is by now in post-COVID, anyway, I don't have to define it. But the hand, foot, and mouth disease is spread easily through person-to-person contact, respiratory droplets containing virus particles when an infected person coughs or sneezes, or through contaminated surfaces and objects. So that is one of the few infectious diseases that actually has it's multimodal in the way it's transmitted. So I'm glad I didn't actually guess at just saying it was person to person, because apparently it's aerosolized as well. Good question. So standard precautions here. So talking about donning and doffing gloves, I'm going to spare you folks the demo tonight, but what we need to do next time we're in class together, try to bring a set of gloves and we'll show you how to properly put the gloves on and take them off. And it's actually harder than you think, as far as, not contaminating, yourself or other people. When we did this class in person, and one of my favorite things to do when I'm training people how to put gloves on is to actually have your people put their gloves on and spray a little of shaving cream or foam on their hands, have them rub it together so that's like your contaminant, and then try to actually safely remove the gloves through that. But of course, digitally can't do that. But anyway, bring some gloves on Saturday and we'll see what happens. So immunizations, influenza, tetanus, Hep B vaccine are all recommended for EMS providers, as well as now the COVID-19 vaccine and associated booster shots. So check the status of your measles, mumps, rubella vaccines, and TB test or tuberculin testing may also be recommended. Depending on your service, it actually might even be required. So just know what those limitations are and whatnot going in. Questions on infectious diseases? Sorry, I meant to button that up before we moved on. Am I echoing?
My computer has you echoing.
Anyone else?
You're not echoing on my end.
You're not echoing on my end either.
Okay.
Everyone's echoing. So I'm going to restart my classroom and come back in.
Okay, bye. We'll see you in a bit. So let's move on to another big safety concern and what we're going to address tonight, responding to the scene. What I'll say about driving, folks, and responding, in all honesty, this driving is probably one of, if not the most dangerous thing we do in EMS. And more people are killed, first responders are killed each year in traffic accidents than any other type of, dying in a fire or being shot or heart attacks or infectious disease. We really need to take more safety precautions in mind as we're responding to the scene. So what I'll also say is most of you folks probably as local first responders in your communities, most of the time you'll probably be taking your own POV, personally owned vehicle, to the scene. So don't be like driving like a Looney Tune, because your department may or may not reimburse you if you total your car. That's a conversation you need to have with them. And your insurance provider may or may not cover you if you're, responding to the scene. I'm not going to go any further into the conversation about that than what I just said, but it's something that you need to look out for. And if you have, authorization from your chief or your department head or supervisor or whatever, to use lights and sirens in your POV, then that's a conversation you need to have with that person. So what I'm going to talk about more generally, though, is responding to a scene. Obviously, you want to get there safely. It's the most important thing. If you're injured or you're dead, you can't help the people in need. Also, you're going to be taking up other resources from other towns now. If if you're going to a medical call and you get into a traffic accident, well, now other resources need to be diverted to the scene to treat your patient, but they need to be diverted to you as well, or mutual aid needs to come in and actually take care of you. So drive safely, always fasten your seatbelt when you're in a vehicle. So don't want to belabor that point, but questions? Nick, go ahead.
Just want to relate that if you have a red light and a plate on your vehicle, you are a visible target to the public. So PR is a most important thing.
Yeah, people like to complain. That's a really good point, Nick. You're like you're a moving billboard. So, and I'm not judging anybody that has plates or stickers or whatever on their vehicles. That's like totally up to you. If you look at my POV, I have lights and siren, but they're all low profile lights. And I don't have any plates or identifiers as to who I am or anything like that, because Nick, to your point, I personally don't want to take on that responsibility of being whatever you call it, a billboard. So
yeah, our department actually requires us to have a plate on our vehicle due to their insurance policy on the town.
Sure. No, and different strokes for different folks, but also different departments have different policies and procedures. And I would never dissuade or discourage you from following any of your local department policy or procedures. So what I will say is New Hampshire state law requires you, if you're going to move through an intersection or run a red light, you need to have both a visual and audio device. So that means lights and siren if you're going to be blowing through stop signs. I'm sorry, safely rolling through stop signs or traffic lights or anything like that. So just be mindful of that. So let's talk about responding to the scene itself. You get dispatched. Use the dispatch information to anticipate hazards and determine how to approach the scene. What do we mean by that? Well, if we had like a flash freeze a couple of weeks ago in southern New Hampshire, and I swear to God, over the course of 20 minutes, we probably had like 15 or 20 vehicles go off the road. And as the ambulance and the people are, the responders are trying to respond to get the ambulance and then start going to these car accidents, they're sliding all around. And it just, use context clues as the dispatch goes out and, anticipate what those hazards are. One of the things I'll do with myself, or if I'm in the ambulance with a partner, I'll ask what some of the threats or hazards or risks are that we anticipate before we even get on scene, and we come up with a game plan for trying to mitigate what some of those are. So just because the patient's on the side of the road, on a busy highway or whatever, doesn't mean, you can't put them in the back of the ambulance and actually move into another driveway or pull into another parking lot or something like that. You don't have to stay on the side of the road. Or what other fire apparatus or Department of Transportation vehicles can you put to make a barrier, from where you park your ambulance? And we'll talk about that a little bit later. So in the response phase, fasten your seatbelts, plan the best route, and drive quickly but safely to the scene. Parking your vehicle. So park your vehicle so that it protects the area from traffic hazards. Again, not telling you what to do, but use your discretion and judgment as to your own use of your own personally owned vehicle versus like a department car. If I'm driving an ALS Intercept car that has 360-degree lighting and it's marked and there's, high visibility markings on it, I might position that cruiser to block or stop traffic. I'm probably not going to put my personally owned vehicle in the way of doing that because it's just not set up the same way to market. So in that event, I would probably pull past the scene and park off to the side. Andrew, go ahead.
One thing I think to build off of the park your vehicle so that it protects the area from traffic hazards is my department stresses to park on the same side of the road as the accident or wherever the incident is occurring, just so you're not, walking across the road with traffic and that sort of thing.
you're jumping the gun on me, but spot on, Andrew, spot on.
Oh, my bad.
All responders we want to try to have on the same side of the highway, and that's for a variety of reasons, right? The more vehicles we can have off to the side with flashy lights, hopefully the more visibility we have. That's the first reason. Two, there's that many more barriers between us being outside of our vehicles and the patient's car or whatever it is that we're treating, so that, if somebody's going to smash into something, maybe it'll stop before it gets to us because of all the vehicles there. And the last reason is we don't want people crossing the road unnecessarily. So think about it. If you park on the other side or the opposite side of the road, now you're causing people to look on both sides and be like, where am I? Like, what's going on? Versus having all the responders off to one side, and now you don't have to actually cross the road because you're on the same side of it. So Andrew, that's a really great point. So thank you for bringing that up. Be sure that the emergency warning lights and siren are operating properly. If you're, going down to the ambulance base or the fire station to punch in for the night, do your truck check, turn your emergency lights on, give the siren a little yelp, and do a 360 around your vehicle to make sure, your lights and everything are working properly. And then, of course, be careful when getting out of your vehicle, not just looking for oncoming traffic, but looking for things like ice that you might slip on, looking for fluids or anything leaking from the vehicle, gasoline or diesel fuel or whatever. Just be mindful of that stuff as you're rolling up on stuff. Anytime you're on the road, state or federal law requires you to wear a safety vest. A lot of our jackets and stuff have moved over to like a high visibility vest where you don't even have to think about it. You're wearing it all the time. What I would say is in an active shooter situation, not ideal. But anytime you're in the roadway, hopefully you have your vest on and, your high vis vest. So if your vehicle is not needed, park it out of the way of traffic. And for you folks that, are doing this for your community, and other first responders and EMS providers and fire folks are going to the scene, like the less vehicles we can bring to the scene, typically the better. So if you can meet up with another responder, or if you can go to your base and grab, fire apparatus or, the ambulance or whatever it is, then I would highly recommend doing that. So when you roll up on scene, we want to do scene size up and assess. We're scanning the area carefully to determine what hazards are present and address them in the most appropriate order. From a traffic standpoint, if we need to control the flow of traffic on a busy highway, hopefully we're calling in police and other partners to help us do that. And if you need more help to handle traffic, call for assistance before you even get out of your vehicle. People tend to yield to blue lights a lot better than they do red lights or yellow lights or orange lights or any color but blue. So you'll also see a lot of now fire apparatus and ambulances are actually putting a rear-facing blue light just because of the psychology behind people seeing the blue and associating it with law enforcement and actually slowing down. So it is making a difference, and that's a trend that we're seeing now in New Hampshire. And New Hampshire state law actually allows for that. So pretty cool. So if you move in, in the vein of scene safety, some of the scenes you may end up on may be a crime scene or an incident of violence. If you are trained in law enforcement procedures, because again, this is an EMR class, so we might have some police officers or law enforcement rangers or some of those folks in this class, I'm not sure. But if you're trained in law enforcement procedures, follow your protocols. If you're not a law enforcement official, either A, stage outside and wait for them to get there, or at a, stage at a safe location, or B, proceed very carefully. If you have doubts about the safety of a scene, wait at a safe distance and request help from law enforcement. Given the geography and how New Hampshire is set up, you might need to wait 15, 20, 25 minutes for New Hampshire State Police or your county sheriffs or, another mutual aid department to get there. So it's really important that you stage away from the scene and you stage at a safe distance, but also that, you recognize early on in the process that maybe something's a little hinky with this call. And that goes back to my point about using context clues earlier from dispatch. If it's a female, 25-year-old female with, couple of, black eyes and the boyfriend's yelling in the background. Well, it sounds like it might be a domestic. So let's get law enforcement rolling before we even pull out of the station. If the scene is a crime scene, take a mental picture and try and do your best to avoid moving anything on the scene unnecessarily. But with that said, your safety and the safety of the patient and the medical treatment of the patient take priority over preserving any crime scene evidence. There are different tips and techniques and tricks you can get into, as far as like if you need to remove a victim's clothing, like putting it in a paper bag versus a plastic bag, trying not to cut through like stab wounds on somebody's clothes or gunshot wounds or whatever, like trying to cut around that if you go to use trauma shears and remove the clothing to expose the area or whatever. But check out the New Hampshire state protocols because some of those considerations are actually listed in there. And those are simple things that you folks can do as first responders as you go to treat the patient. So questions on crime scenes?
What would you do if you had like a non-violent patient to start who turned violent and like started assaulting you and law enforcement was not around, but you're already there?
Yeah, great question. You're going to break contact and you're going to go get in your ambulance and drive down the road to a staging area. If the person's combative and that violent and trying to assault you and your partner, then you need to get out of that situation. And then you need to stage away until law enforcement can get there. Great question. Other questions about crime scenes? You folks have serial killer coloring books. How do you not have more crime scene questions? All right, moving on. Assessing the scene. So crowds, assess the crowd's mood before you get into a position from which you cannot exit. Ladies and gentlemen, there have been a ridiculous amount of riots or crowd situations in the past couple of years. Thinking about the festival that they just had out in, I believe it was Texas. Thinking about, some of those just associated concert venues where people get kicked in the head and mosh pits and things like that. Looking at the U.S. Capitol riots and the insurrection down there, crowds can be really either friendly or hostile. There's typically not a lot of in between. And I say that not to say that, it's either or, but by and large, it's either a friendly place to be and you have the room to move and do what you need to do, or not so much. It's out of control in a hostile environment. You want to take the time to really assess the crowd's mood before you end up running into a crowd, and make sure you have a plan for ingress and egress out of there. Really important. If you need to get help from law enforcement officers, they can also help you, either provide force protection to you and your partner and form a perimeter and move people back, or subdue the crowd in other instances and using other techniques of crowd control. If the scene's not safe, the scene's not safe. Don't feel like you need to be Ricky Rescue running in there trying to save everyone, right? Step off to the side, try to instruct the patient or bystanders to do what they can to treat the patient. But at the end of the day, it's not worth putting yourself in harm's way. So, and then finally, electrical hazards. Don't approach, actually, there's some other hazards we'll talk about, but electrical hazards, don't approach the scene and keep other people away from the source of the hazard. Electricity is nasty. It really, if somebody's electrocuted or whatever, and they're still touching a wire, or you're not sure if they're touching a wire, you got to make that scene safe before you go and grab onto them. So make sure that, and to that point, make sure the electrical current's been turned off by a qualified person before you get close to the source. Wear a helmet with a chin strap and a face shield. Yeah. Fires, if you're a trained firefighter, follow your rescue and firefighting procedures. Obviously donning and doffing the proper personal protective equipment is really important there. If you're not a trained firefighter, don't exceed the limits of your training, and never enter a burning building without your proper turnout gear and SCBA. hazardous materials. Hazardous materials may be found almost anywhere. And a lot of times we don't think about these things like, hey, I've got all these cleaning products under my sink or in my bathroom, and now all of a sudden, there's a spill and they're coming together to make methyl ethyl bad stuff. And that's what's making people sick. Or things like carbon monoxide is an odorless, colorless, tasteless gas that a lot of like generators and furnaces can omit and make people sick and have medical types of signs and symptoms like nausea, vomit, diarrhea, things like that. So as you're doing your patient assessments, be taking in the surroundings and trying to figure out what's going on at the scene as well. When we talk about actual like federally recognized and declared hazardous materials, what's important to note is that all transportation modes, so like airplanes, delivery trucks, cargo ships, things like that, are required to have hazardous material warning labels. And what's cool about these labels, it actually tells you everything you want to know about the chemical itself. And this isn't a hazmat class, so I'm not going to go too far into it, but depending on the color and patterns, as well as the different classifications, it tells you about, the different hazardous materials and whether, how to basically treat your patients with it, how it can, how these chemicals react to things like water and other elements, how you can contain them. If you don't currently have the emergency response guide or ERG downloaded to your smartphone, take the time to do it. And I'm going to show you on my phone. If you just Google, or not Google, but if you go to your Apple Play Store or your Google Store or whatever, and you type ERG 2020, there's a free app you can download. And the ERG app version is really cool because what it allows us to do is actually search by name. So if we know what, the name of the chemical is, if we know what the placard looks like, we can start to sort down, and it tells me exactly what that chemical is. And again, how to treat my patient, if it's airborne, how far of an evacuation zone we need to set up. It's also got some mapping features that are available. So if you're dealing with something like chlorine gas or other gases, it'll geomap where you are and show you, depending on which way the wind is blowing, where your evacuation zones need to be. So it's a really, we could like talk about that for like 8 hours and not cover all of it. But just know as EMRs, hey, you need to recognize, before you go running up to a truck that's on its side, does it have any of these hazardous material placards? And if so, what are your tools and resources for starting to sort out what is what the container is actually carrying? All ambulances and I think rescue vehicles in the state of New Hampshire are required to have a copy of the ERG, the Emergency Response Guidebook. It's an orange book. Or, also download the app because the app's wonderful. So, and I get $1 every time one of you folks downloads it. No, I'm just kidding. It's a great app though. It really is good. So questions on hazardous materials?
Just remember too that UPS trucks, FedEx trucks, they will not be placards. So you have to remember that if one of those vehicles is involved in a crash, that you also have to proceed with caution. And that's what they taught in hazmat classes.
That's awesome. Yeah, that's a great point, Melissa. Thank you. They're one of the few transportation carriers that's not actually required to disclose because they don't know what the items are. Although Joe Blow citizens shouldn't be shipping hazardous materials through the mail, but they do. So, Nick, go ahead, sir.
Just keep in mind, if you come across an accident, possibly a mechanic or an elderly person that has oxygen or oxyacetylene on board in their trunk that you may not know about it, you may have a big issue.
Sure. Yeah. Different things react differently. Also, the oxygen cylinders we carry on the ambulance or any other compressed gas, scuba tanks, those can all very easily turn into projectiles. So, if you believe the crash involves hazardous materials, stop uphill and upwind and use binoculars to observe the scene. I teach some cops sometimes, so cops like donuts. So what I tell them is do the powdered donut trick. And basically you take the powdered donut, it has to be a powdered donut too. And if the whole scene can't fit through the middle of your donut, the donut hole, then you're too close. You need to move your cruiser back. Also, if when you're holding your donut up to the scene, if the powder comes back on your uniform, you're facing the wrong direction. You need to turn around. And that really resonates with them. But anyway, powdered donut trick. The other thing is the thumb trick. You can take your thumb, and if your thumb can't cover up the whole scene, you're too damn close. So anyway, hazard, it's fun stuff. So heaters, yeah, propane tanks used for heaters and fireplaces. Great point, Catherine. Thank you. Odors of fumes may be the first indication, unless it's something I mentioned earlier, like carbon monoxide. That'll make you and your partner sick or even unresponsive before you even know it. So calls for assistance. Anytime we have a hazmat incident, every jurisdiction is required to have plans and appropriate mutual aid resources to handle hazardous material incidents. Just know what your local policy plans and procedures are. Anytime, moving on from a hazard standpoint, other hazards, unstable objects. So what are we talking about here? Well, vehicles, trees, poles, buildings, cliffs, and piles of material can all be unstable. I know in Brookline, like some of the worst traumatic calls we've had have been with farm equipment and whatnot. So it's really important that, a tractor or whatever it is that's run over a person is properly stabilized prior to actually trying to extricate the person or whatever. Same with cars that are, maybe a tire's pumped or, rolled a couple times or whatever. Just be careful what you're crawling into and make sure it's stabilized. Hey, on that topic, unstable objects, vehicles may need to be stabilized before patient extrication can begin. You folks should note that most vehicles, almost every vehicle on the road nowadays probably has some type of airbag in it. And after an accident, these airbags can be hazardous to your patient, but they can also be hazardous to you. The worst offender, in my opinion, is the old steering wheel airbag, and some fire departments and rescue groups carry. It's a cover that you put over the steering wheel that if the airbag were to deploy, it would be contained. So just know what your resources are and don't go crawling into cars that A, aren't stabilized, and B, you have concerns about the airbags deploying on. So fires and explosions can result in unstable buildings. Okay, so we're not entering structures that, aren't structurally sound. Sharp objects, obviously concerns for broken glass, especially at the scene of a motor vehicle accident. So if you're in the business of, if you're on a joint fire department or your EMS service does rescue and extrication, take the time to get the training on that and really make sure you're wearing the proper personal protective equipment, heavy leather gloves over your EMS gloves or whatever, so that you have that double layer of protection, right? Because we still want to protect ourselves and protect our patients from the standpoint of, bloodborne and other pathogens being transmitted from us to them or them to us. But we also need to put our gloves on and, an outer layer of the gloves, and make sure we're not getting caught up or cut on glass or whatever. Animals can also be a huge safety hazard. Not all pets are friendly, even the friendliest pets, if you go to make a move on their owner or whatever, can turn on you pretty quick. So we try to lock up the pets or, call the patient out of the house if we can. Farm animals, wild animals, obviously, don't need to talk about the dangers that they can present, but something to think about. So animals can obviously bite, kick, or even trample you, depending on their size, or I guess your size too. But, and then finally, from a safety perspective, environmental considerations. So making sure that you and your crews are dressed appropriately for the expected weather. Be alert for possible damage due to high winds, so damage to trees, damage to any of the infrastructure that your supplies and equipment. Keep your patients dry and comfortable. Do the best you can to get them out of wet clothing. Isolate them or insulate them from the ground if you can. The ground sucks out a lot of heat and temperatures. And then finally, use emergency lighting when operating in the dark so that you can help avoid hazards. Assessing the scene, some different or special rescue situations. Water rescues can include ice rescue, water rescue. Other situations might include confined space or below grade rescue, terrorism or mass casualty incident response. There might be different considerations for how you or your department address these specific threats and hazards. Just know what your tools and resources are, know what you're looking for, and do it as safely as you possibly can. Finally, don't enter any emergency situation that is unsafe unless you have the proper training and equipment. Your safety, your partner's safety, the safety of your patient. All right, folks, so that brings us to the summary section of our first chapter here, chapter 2. So what you need to know: stress is a normal part of an EMR's life. Do your best to mitigate that stress the best you can. The 5 stages of grief, or the grieving process, is that DABDA model I talked about: denial, anger, bargaining, depression, and acceptance. Also note that stress management consists of recognizing, preventing, and reducing critical incident stress that you folks might experience on different calls or incidents. Not just stress within you, but stress within your fellow providers or responders. You should also understand how airborne and bloodborne diseases are spread, and how standard precautions like your BSIs, your body substance isolations, can prevent the spread of infection. I think after the last couple of years, you folks probably have a good handle on that. And finally, as you arrive on the scene of a collision or illness, take in the scene and look for different hazards. Take into considerations things like traffic, crime, crowds, unstable objects, sharp objects, electrical issues, hazardous materials, fire, animals, environmental considerations, infectious disease, as well as special rescue situations. So help me blast through this review here. Common signs of symptoms of stress can include increased appetite, decreased muscle tension, greater ability to think clearly, and irritability. What do you folks think? Seeing a lot of D's.
I'll go with D.
Survey says, Catherine, I agree with you. A and D, increased appetite. Like I don't know. It can also be decreased appetite, but the textbook says it's D. Some people like me use food to cope with stress, though. Anyway, all right, moving on. You are called to the scene that seems you are called to a scene that seems unsafe. What is your best course of action? A, refuse to respond. B, wait a safe distance and request law enforcement. C, proceed to the patient but use caution. Or D, put the needs of the patient ahead of your safety. Perfect. Seeing a lot of B's here. Survey says B, wait a safe distance and request law enforcement. I think that's a bad question because it really doesn't define how the scene seems unsafe. So like if it's a hazardous materials incident, I'm not going to call law enforcement. I'm going to call a hazmat team. So kind of a bad question, but you folks got the core of what it was after. And then finally, which of the following is not a consideration when responding to an emergency scene? Road conditions, other drivers on the road, personal safety, such as a seatbelt, or always using lights and sirens. David said D. No, B. He said B. Survey says the answer is D, always using lights and sirens. We don't always use lights and sirens on every call. So questions on anything we covered in ambulance? No, sorry, not ambulance. In safety. Workforce safety and wellness. Alrighty then. Ready for chapter 19? Let's hit it. All right. So chapter 19, transport operations. In this chapter, we're going to talk about your operational roles and responsibilities to ensure for a safe patient, public and personal safety. And a lot of this ties into what we just discussed in chapter 2. So it'll be a nice, easy way to run out the clock here for tonight, folks. We're also going to talk about the principles of safely operating a ground ambulance, risk and responsibilities of emergency response. And then we'll get into a little bit more about air medical transportation, to include safe air medical operations, as well as what some of the established criteria are for using them. So to be an effective emergency medical responder, you need to prepare for the call, review and analyze some of that dispatch information. We talked about that during our last module. Respond safely to the scene, perform a scene size up, perform your initial assessment and provide emergency care based on what the findings of your initial assessment are. Update other responding units and transfer care to the other emergency medical service personnel, and complete post-run activities. And we're going to talk about these different phases and get a little bit deeper into each and every one of them here. So step 1 is preparing for the call. So you respond using a fire department vehicle, law enforcement vehicle, your private vehicle, or on foot as an emergency medical responder. You know, those are some of the different ways you might get to the scene. It's your responsibility to ensure that vehicles, you know, any response apparatus or vehicles that you folks are using is in a response ready state, so that it has gas, there's air in the tires, your emergency lights and sirens are working. You know, that onus is on you, especially if you're, you know, dedicated to working at a station or something like that. Follow a regular schedule to inspect and maintain all vehicles. Most departments have some type of maintenance plan or maintenance contract or whatever. So it's really important that, you know, you fulfill and see that, as well as, you know, do your inspection of your supplies and equipment, which we'll talk about in a little while. I mentioned checking things like tire pressure, fluid levels, fuel levels are really important. Obviously, we can't go anywhere if we don't have gas or fuel. As an EMR, you want to be prepared to respond quickly using the most direct route available. What I will say about that is sometimes the most direct route available isn't the safest route. So you should take some time and, you know, put some thought and considerations into that as well. I used the example earlier of icy roads and whatnot. So, you know, working through our DPW, Department of Public Works, and our plows to know what roads were safe to travel that day when we had the flash freeze over, and which ones were not. So, and of course, you know, ensuring that you folks have the proper equipment to perform your job. And I talked about this a little bit last Wednesday. Some of the supplies and equipment you may carry in your first in bag or your response bag. And you can see in the picture here, again, I think this picture is probably older than I am. But, you know, there's an old joke out there, like, what do you call a paramedic without an ambulance? Does anybody know? You call them a bystander, because there really isn't anything a paramedic can do without an ambulance. If they don't have their medications, if they don't have the cardiac monitor, if they don't have the advanced devices to actually treat the patient that they need, then there's no difference between them and a civilian. So all that to say, just know what your supplies and equipment are that you need, and make sure you have them and they're in good working order. Here are some suggested contents of an EMR life support kit. It's in your book. Also, moving on. Phases of an EMR call. So when you get the initial dispatch, and again, we talked about this a lot last Wednesday, you know, a dispatch facility is a center that citizens call to request emergency medical care. In the state of New Hampshire, if you call 911, it goes to our state PSAP, Public Safety Answering Point, over in Concord. And then depending on what jurisdiction you're located in, Concord will then transfer the call or involve your local dispatch center, who will then tone or page you out as responders. So the dispatchers are trained to obtain proper information from the caller and instruct callers on how to perform life-saving techniques such as CPR until you arrive. What I want you folks to note, and this isn't in your book, but there's another level of EMS provider that National Registry doesn't actually recognize, and that's emergency medical dispatcher. And what I want you folks to know is that there's really two types of dispatchers out there. There are those that are EMDs or emergency medical dispatchers, and those that are not EMDs. In the EMDs, the emergency medical dispatchers have specific run cards that they look at when a call comes in. And if it's a medical call, they will go through and they'll start doing kind of initial assessment in triage of the patient. And then they will make recommendations based on what it is they're hearing. For example, if someone calls in and they're conscious, alert, and oriented, but they're bleeding, the 911 dispatcher will provide them or whoever is calling into 911 with instructions to stop or mitigate the bleed. That's one example. Another example is if the person's not conscious and not breathing, the EMD, the emergency medical dispatcher, is trained to talk that bystander through starting hands-only CPR so that care can be rendered to the patients before we even get there. And it's something that's not in the book, to my knowledge, and something we don't spend a lot of time on. But just know not all dispatchers are emergency medical dispatchers, and just kind of understand the difference a little bit. So, yes, 911 emergency show used to be good. All right, pushing on. Information from your dispatch. So here's my disclaimer. And again, I'm not picking on dispatch, but as EMRs, you folks will be dispatched to a call and you'll get there and it'll be something completely different. I promise. If it already hasn't happened to you, it will. And what it's like that old game of telephone that we all played in like elementary school or whatever. You got to think, like, if somebody sees something going on and somebody needs medical attention, like they're seeing it unfold. How they perceive whatever is going on is up to that individual. Then they're going to call a dispatcher and tell them what they think they saw or what they think the issue is. The dispatcher is then going to compile that information and figure out, based on the information they have, what they think is going on. They're then going to call your dispatch center and tell them what they think is going on, who will then in turn tone you folks out or call you to the scene. And you have to receive that information and perceive from your own standpoint what's going on. So that's a long-winded way of saying I've been toned out or called to some like ridiculous whatever, like, fall, like, hey, we have a 50-year-old male that's fallen. And I'll get there and it'll be like, an 85-year-old female that's on the ground in cardiac arrest because they fell to the ground, but they were also clenching their arm because they're having chest pain and they're in cardiac arrest. So, all that to say, not that you shouldn't believe what your dispatch center is telling you, but like just recognize that stuff happens. And as licensed and credentialed professionals, when you get out there, use your discretion and judgment. And I'm sure you folks have tons of stories that you could tell for anybody that's been on the department or departments for a while about, your dispatch for one thing and you get there and it's something completely different. So in their defense, it's garbage in, garbage out. And what I mean by that is if the caller gives them bad information, then they can only, relay that bad information to us. So it is what it is. But hopefully they're getting an understanding of what the nature of the call is, the name and location of the patient. If there are multiple patients, what the number of patients are so that they can dispatch the appropriate number of resources, and any special problems or hazards that are in the area. One of the big ones recently, 911, well, not recently, but within the past 2 years, 911 started screening for COVID-19. So, and they would say, hey, you know, protocol 36 confirmed, or code purple confirmed, or whatever the dispatch, you know, your dispatch center is using to denote that, you know, the patient's been screened and either has COVID and has identified having COVID, or doesn't have COVID, or at least passed the screening questions. And then hopefully they're getting a callback number from the caller. Ideally, they're not disconnecting with these people. They're trying to keep them on the phone until you get there. And if that's the case, when you get there, you can just tell them to hang up, or you can say, you know, don't just tell them to hang up. Tell them that you're, you know, that you're here, and they can disconnect with 911 and tell them, you know, responders are there. Or if they give you the phone, you can just say, hey, it's, you know, Dave News, Advanced EMT. I'm on scene with the ambulance. We're all set. Thanks for your help, type of thing. So, questions on dispatch at all, or anything we've covered? Yeah.
Dave, quick question for you. So I had to step out for a second, but you said when people call in for 911, it's out of Concord, for instance, and then Concord dispatches out to the other dispatch departments?
Yep.
Okay.
So Concord is the public safety answering point where you call 911. That's where your call in the state of New Hampshire goes. And then they figure out where you are, and they call you folks, your department's dispatch center. So, you know, that might be your county dispatch. In my instance, down in Amherst, we have our Amherst police dispatches, police, fire, EMS, and DPW. Concord will notify your geography or your jurisdiction's dispatch center and start relaying information.
So it would be for Concord first, and then like I'm Lakes Region, so they would contact Lakes Region and they would go out to me. Okay.
Yep. All 911 calls in the state of New Hampshire go to Concord, unless they, you know, a caller calls in directly to Lakes Region, or somebody calls in direct to Amherst Police, which happens sometimes, but not all that often. The majority of the dispatchers that sit in your local dispatch centers are not EMDs, those emergency medical dispatchers. Some are certified, most are not. So that's why we encourage people to call 911 at this, you know, this quote PSAP, the state 911, because that's where those dispatchers typically sit. Other questions on dispatch? They're great too. I'm not ragging on dispatch, I promise. So your response to the scene, I don't want to belabor this point. Get there quick, get there safe, wear your seatbelts. Don't drive excessively. Don't drive like an idiot. And that's basically all we need to say about that. Once you get to the scene, you know, do a scene size up, put your vehicle in a safe location, look for hazards. If you need to control the flow of traffic, do that. And this is actually a point that's in your patient assessment that we went through on Sunday. You know, one of the things you folks need to do as first responders is identify the number of patients, but also the resources, the additional resources that are needed. So I used the example of a hazmat truck earlier. If we need to get Department of Transportation trucks there because a bridge or some type of infrastructure is damaged, that's all information you folks can actually relay to your dispatch center and get those resources ordered up and on the way. As well as if you need additional ambulances or whatever. So, and then provide patient care. So, transferring the, Catherine, go ahead.
So I do have a question because I know it happened recently here in Charlestown. So say there was like a spill of gasoline or diesel and it was going into like a river. Who then would you call?
Yeah, so the Environmental Protection Agency, not the federal, but like the state has an environmental response hotline that's staffed 24/7, and they have a team that can mobilize to deal with that.
Okay.
Yep, DES, Department of Environmental Services.
Thank
you.
you.
Your dispatchers should have the numbers and stuff for those folks. But the fact that you get there and you recognize that that's going on, you can start, you know, share that information and relay that onto your dispatch center. So that's a great example. So once you arrive on the scene, oh, we already did this one. Perfect. Transferring the care of the patient to the other EMS personnel. So one of the things I talked about at length with the crews in Concord on last Saturday was kind of the transfer or the handoff of patient care from you folks at the EMR level to maybe, a higher level provider like an EMT or an ALS provider, like an advanced EMT or a paramedic. And, some of the things we want to give them a brief on, really, the situation, what resources were ordered and kind of what's going on, as well as, if what your assessment findings were of the patient and what you've done to address any medical concerns. So, sometimes depending on how your local department operates, when you get there and you realize, okay, this isn't a critical emergency or whatever, I can get a good set of vitals, and then I'm going to update whoever my transport unit is if you get, another ambulance coming in, or if you've called for an advanced EMT or paramedic ALS intercept type thing, you folks can call, those other responding units and give them an update of your patient about, what your assessment is and, quickly what you've done to address it. They don't need to know about the hangnail or the heartburn or, whatever. But, what do they need to know from like, hey, 10-second snapshot of this patient. This is what I found. This is what I've done. And this is what we're doing. So kind of when you do that hospital patch, and I think the other sites, Walpole and Bethlehem, talked about hospital patches, hopefully on Saturday as well. But at some point, you folks as EMRs are going to have a handoff to a higher level provider, be that an EMT or an ALS provider. So questions on that handoff or any of the information you want to share with them? So your post-run activities here. So after you finish your call, obviously you want to complete the paperwork. Again, as EMRs, depending on what your department's policies or procedures are, you might be responsible for, doing an in the New Hampshire State Census, or if you're on, if your service transports and you end up going with the patient and the other providers to the hospital, building or writing a census report and documenting everything that you did and other providers did for that patient, as well as writing your narrative, is really important. So really the job of an EMR isn't done until we, put the ambulance and our equipment back in service, but also until after we've completed our report. So don't put yourself in service until your supplies and equipment are squared away. As far as putting yourself in service before the paperwork's done, depending on what your local policies or procedures are, some services, that's not how they operate. Other services, most services will put ambulances and crews back in service before the narrative's written or the documentation aspect is done, because they want to make sure they're ready to go for another call if they need it. So your post-run activities. Helicopters aren't supposed to fly. They beat the air into submission. Helicopters are really dangerous when you stop and think about how they operate, compared to like a fixed-wing aircraft. Tons of helicopter accidents and mishaps and everything. And just like helicopters should not fly when you stop and think about how they operate. So we do use helicopters a lot in EMS, specifically for those hard to reach patients, or those patients in the wilderness environment, patients with delayed transport times to, specialty hospitals like burn centers or, stroke centers, things like that. Yeah, and I just hit that point. So duck your head and stay alert. Yes, you're right, Catherine. You'll see here in this photo, Maryland State Police actually does their medical evacuations down in the state of Maryland, which is pretty cool. In New Hampshire here, we have some different providers. We have DART. Dartmouth-Hitchcock is a huge air medical provider. We also have Boston Med Flight, Life Flight out of Massachusetts as well. We've got some providers that'll come over from Maine. So, when you're like, oh my God, they're coming over from Maine, like, or coming over from Western Mass or whatever, it's really not that far when you're going by aircraft, and the speed at which these things fly is pretty impressive. So, know what air medical transport assets are available to your service in your communities, and figure out which ones your dispatch centers use. And then you folks will be in good shape. So, helicopters have several advantages. They can respond quickly above traffic congestion and go out to wilderness areas, which makes them really valuable. They usually carry specialized equipment. One of the big things is blood products and other advanced medical devices and medications that we don't typically carry on the ambulance may be available on helicopters. Most helicopter crews also are consist higher level providers. So a lot of times we'll have a flight nurse or a PA or a doc, even a doctor on the helicopter. It's not uncommon to see that, or or a critical care paramedic. Probably the most common configuration is a flight nurse and a critical care paramedic. But these folks are, I have a lot of respect for them. They really have mastered their skill and their trades. And anytime I've ever worked with any of the air medical folks, it's been an absolute pleasure. So in that vein, having higher level providers sometimes allows them to provide additional or advanced skills that we're not able to perform in the ground ambulance or legally allowed to perform certain procedures in the field. So a lot of times they can do, I talked about last Wednesday, RSI, the rapid sequence intubation, where we'll make somebody unconscious and then we'll take over ventilating them so we can intubate them and breathing on their behalf. Not all services in the state of New Hampshire have that, but most, if not all, of the air medical assets and crews can actually do that. So one of the negatives to helicopters, of course, they're expensive, but they're also limited by bad weather. So depending on the service, they have different reputations as far as what their risk appetite is for flying. We'll joke that certain crews only come out on, like a sunny day, where other crews, will brave the elements. So just kind of know what your services reputations are, and it doesn't hurt to ask. So if your EMS system uses a helicopter, obtain a copy of the ground operations procedure. So we need to land these things, right? Like we call for them, we need to be able to land them. So that's pretty important. We want to obtain a copy of those procedures and be familiar with where your landing zones are, who from your jurisdictions are going to be setting up the landing zones. A lot of times they'll send out a fire crew to do that because they have, their fire trucks are nicely lit up, but B, they have the right size crew to actually establish a landing zone. 3 or 4 people on a fire engine can definitely run a landing zone, as well as some of the lighting that are on a lot of the fire apparatus can light up a soccer field or football field or wherever it is that we're landing these things, parking lots, etc. If your service does, actually, most everybody's service has helicopters. See if you can get an orientation session scheduled with these folks. They love coming out to your communities and actually, touching down and getting out and letting you take pictures of the helicopter and going in and seeing things and talking about kind of how to safely operate around the helicopter, which we'll talk on a little bit here, but not as thorough as they do. And then finally, know how to request a helicopter response, as well as what the criteria for calling a helicopter is for your patients. And we'll take a look at that in a couple minutes here. So I have 8:10 folks, which means we've been at it for an hour. So let's go ahead and take another 10 minutes. When we come back, we've only got another 13 slides, give or take. And I want to talk through what our helicopter protocols are for New Hampshire so that you folks don't have any, so you're familiar with it. So let's go ahead and take a 10-minute break and we'll reconvene at 8:20. All right, folks, I've got 8:20 on my end, so let's dive back into this. Like I said, not that many more slides to go through tonight, and a bunch of those are actually review slides. So before I go any further, though, I wanted to take a minute and introduce you folks to the New Hampshire State Patient Care Protocols, because I've been referencing this document, I think, a lot, and hopefully your other instructors have as well. As you go through your training, this document can be both a blessing and a curse to you. What I would dissuade or discourage you folks from doing is reading too deep into our New Hampshire state protocols, because as we discussed last week, we're training you folks to a national standard, and the national standard doesn't always align with what the New Hampshire state protocols allow us to do, and vice versa. So just take this document, if you start looking through it, with a grain of salt, and just, you know, as you study up and whatnot, don't study out of this protocol book, but study out of your regular book. But what I wanted to show you folks, if you just Google New Hampshire State EMS protocols, it'll come up, or you can go through the New Hampshire State Bureau of EMS website and find a copy there. But I thought it was germane to actually take a few moments as we're talking about helicopter operations tonight, and actually review what the criteria are for calling helicopters here in the state of New Hampshire. So you'll notice the protocols are broken up by certification level, all the way from EMR up to paramedic. And the idea here, just to pull up one of the protocols as an example, is to look at, tachycardia is kind of a heavy one. Let me see here. Wow, these are all super heavy. Hold on a second here. Let me find something a little bit easier to. These look complex and confusing, but they're really not, I promise. Seizures. Let's look at seizures here. So you can see the seizure protocol is for 2.18, and this protocol directly applies to our EMT and advanced EMT level, as well as our paramedics. So if you go to a seizure call, this is what our providers are allowed to do. Our EMTs and advanced EMTs can provide routine patient care. They can check a blood glucose reading and administer additional blood glucose. We can give glucagon and glucagon based on, you know, the patient's condition in accordance with the hypoglycemia protocol. And we can assist in midazolam if they have a prescription for that, as well as use a VNS magnet, which again is a little bit outside the scope of, you know, what you folks are going to be learning in this course. But this is very prescriptive, and this is kind of our playbook or our recipe book for as to how we treat the patients based on our assessment and our findings. A paramedic can not only do everything that the EMT and the advanced EMT can do, but they can also, if they're actively seizing, give a patient midazolam, lorazepam, or diazepam, as well as, you know, as you can see in the instance here, a patient in their third trimester of pregnancy or postpartum who is seizing or postictal can get magnesium sulfate. So this is kind of, you know, our cookbook, if you will, or a recipe book, our playbook for how we treat patients depending on what it is we're seeing and what type of medical episode or episodes they're experiencing. Questions on the protocol so far? So one of the protocols, they're not just from a patient treatment standpoint, but EMS operations. So you'll see here, there's a protocol for hazardous materials exposure, mass casualty, and multiple casualty triage, as well as radiation injuries. You'll also see up here more of the medical procedures, air medical transport, communications failure, crime scene preservation of evidence. So we'll take a look at the air medical transport and the crime scene tonight, just to talk through it. So if we click on the hyperlink here, we go to our protocol for air medical transport, and you can see here it outlines what the operational conditions and the clinical conditions are for when we can call for a helicopter as EMRs, EMTs, advanced EMTs, and paramedics. So it's, I'm not going to read the whole thing to you if you want to look it up later. But it says when a patient meets the defined clinical criteria listed below and the ground transport time to the closest hospital capable of providing definitive care exceeds the estimated time of arrival of air medical transport, or the patient location, weather, or road conditions preclude the use of an ambulance, or multiple patients are present that will exceed the capabilities of local hospitals and agencies. Those are the 3 operational criteria in the state of New Hampshire for when we can call for a helicopter. Those are just the operational criteria. Clinical criteria or clinical considerations, things like severe respiratory compromise with respiratory arrest or abnormal respiratory rate. Circulatory insufficiency. So it's defined as a sustained systolic blood pressure of less than 90 or a MAP, mean arterial pressure, of less than 65. Neurological compromise. So GCS, we'll talk about GCS in one of our other classes, but if their GCS, if they can't follow commands, their GCS is less than or equal to 13. For trauma, we can call it for penetrating injuries to the head, neck, or torso and extremities proximal to the elbow or knee, or chest wall instability or deformity. Major burns with greater than 20% burn surface or body surface area, and we'll talk about that in one of our other modules. Electrocution injuries with loss of consciousness or cardiac arrhythmia. A STEMI, which is a fancy word for a heart attack. A stroke, or critically ill children, including those with acute decompensation of chronic and or special healthcare needs. So very specific criteria for when we're calling for helicopters and when we're not in the state of New Hampshire. It also has some additional notes as to who is ineligible for air medical transport and some other considerations. Like hazmat, we're not going to take a patient that's contaminated and put them in an ambulance because now the ambulance is totally contaminated. Talk to med control if any of the above cases present or whatever. Patient, air medical transport's not indicated for patients in cardiac arrest. So, take some time to digest this, look it over, and just know kind of what the criteria are, at least for the state of New Hampshire. You're not going to be tested or quizzed on it, in this course or on the National Registry or anything like that. But it's important that you, when you get out in the field, that you know where to reference and look for this material. Questions on air medical transport or the protocols? I just want to note too, the caveat here, the use of air medical transport is determined by the pre-hospital provider with the highest medical level providing patient care. It should not be determined by police or bystanders. So if your fire chief is there and they're not trained as or licensed as an emergency medical responder, it's you and your crew's call as to whether or not the patient needs a helicopter. Same with the police. They shouldn't be calling for helicopters before you get there and do your assessment and make the determination. Werner has a great question. Can medical director override these guidelines? Absolutely. So if you have a patient that you're on the fence whether or not they meet the criteria, or maybe they don't meet it, but you think it's in the patient's best interest, call med control, tell them what you got going on, and let them make the determination. But yes, they can override this protocol. There is a lot of leeway and latitude in this too. As conservative as we want to be with helicopter use, you could argue many patients could meet the criteria for this, depending on what you're dealing with. So, Nick, go ahead.
So you're saying that the fire chief or a higher rank command in the fire department doesn't have that obligation to request a med flight?
What I'm saying is legally the determination by New Hampshire state law is up to the highest medical level provider providing patient care. So if that fire chief or police chief or whoever is on scene and they're an EMS provider, so an EMR, an EMT, advanced EMT or paramedic, and they're doing patient care, then absolutely they can do that. If they have no EMS licensure or certification, by letter of the law, it's not their decision to make. Do you see how that can be fun sometimes?
Yeah, that's kind of hard because you'll be stepping on a lot of toes and crossing a lot of lines if you were to step in and say, hey, that's not your decision, even if we are an EMT and you have a fire chief running the fire ground.
Yep. No, and that's, you know, your departments and your systems need to figure out how to have those conversations. I've never had a problem with a fire chief or you know, a fire officer on scene. When I've asked for a helicopter, they're like, okay, yeah, we'll go set up a landing zone and blah, 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 blah. Sometimes we've had instances where they want to call for a helicopter, and yet the patient really clinically or by this criteria doesn't meet the need for a helicopter. And what I'll say to the group here is, you know, we're advocates for our patients, because at the end of the day, the patient and or their family is actually the one stuck with the bill. The helicopters are expensive. I mean, you're talking over $20,000 probably for a ride in a helicopter. And that's on the low end. So we need to advocate for our patients. Good question. Catherine.
So my dad actually just had a stroke about probably a year and a half, almost 2 years now.
Mm-hmm.
And they actually flew him to Dartmouth. And he ended up getting a bill. It was right around like $24,000 to $25,000.
Yeah. I'm sorry to hear that. I hope he's doing better now, but you know, see, occasionally I know what I'm talking about from a cost standpoint, but
yes. So he is doing better. He just can't work.
Gotcha. So other questions on air medical transport or the protocols? The other one I wanted to look at real quick with y'all was the notion of crime scene, because it actually underscores some of what we talked about earlier from a crime scene kind of preservation standpoint. So you'll see here, New Hampshire State Protocol 8.7 addresses crime scene preservation of evidence. It says if you have been dispatched to a possible crime scene, including motor vehicle incidents, or you believe a crime has been committed, immediately contact law enforcement. Protect yourself and other personnel. You won't be held liable for failing to act if a scene is not safe to enter. Once a crime is determined safe by law enforcement, initiate patient care and contact and provide any medical care if necessary. Some of the tips, and we didn't get into the details of this during our lecture, but you know, things like having EMS providers use the same path of where they're walking for entry and exit if feasible, so we can, you know, maybe mitigate footprints and things like that, as well as show the police and the crime scene investigators exactly where we came in and came out of, so that they can use other clues on scene to hopefully prosecute. Try not to walk through fluids. You know, at the end of the day, like, that's just a good rule of thumb. So do not touch or move anything at a crime scene unless it's necessary to do so for patient care. Can folks hear me okay? Just a thumbs up. Okay. My connection, it says, it was going out. So avoid moving or touching firearms. Observe and document original location of items moved by crew. Don't cut through clothing, holes made by gunshots or stabbing. We talked about that earlier. If you remove any items from the scene, like impaled objects or medication bottles, document your actions and advise law enforcement. Do not sacrifice, and I think this one should be at the top, but it's not. Do not sacrifice patient care to preserve evidence. And we spoke to that a little bit earlier. You can request law enforcement to accompany you in the back of the ambulance to the hospital if need be. And then a lot of this comes down to documentation. You want to document statements made by the patient or bystanders on your patient care report. If and when it goes to court, you know, you want to be able to recall what was said by whom. Yeah, anyway, we also, if you bring the patient into the hospital, you want to let them know that, you know, this is a victim or this is a patient from a crime scene, so that they can follow their appropriate protocols as well. You know, a lot of hospitals, or nearly every hospital, has a process for handling abuse or like sexual abuse cases, rapes, things like that, and very standard processes that are important to follow so that you know, they can hopefully, well, they want to get the treatment to the patient that they need, but B, they want to be able to prosecute and hold up the chain of custody and chain of evidence, you know, so that hopefully the police can get a conviction if need be. So questions on any of that? I know a little bit of a rabbit hole, but I thought it was germane to what we were talking about tonight. Andrew, go ahead.
So the protocols, it seems like they are, instead of being very strict, they're much more guidelines. But I'm not sure if some of those protocols are a little bit more to the point and strict, and some are more so guidelines, I suppose, if that makes sense.
Yeah, so provider discretion is important, and when in doubt, you can always call med control, but you will be asked why you didn't follow a specific process that's outlined. And as long as you can reasonably defend your actions and explain why you did or did not do something, at the end of the day, that's, you know, if that's what you did to do right by your patient, then nobody's going to question that.
Appreciate it.
Yeah, good question. Cool. All right. Jumping back into helicopter operations here. So helicopters can be dangerous. I told you earlier, they're not supposed to fly. They fly by beating the air into submission, right? The main rotors spin at a rate of 300 RPM, and they cause 4 feet just above the ground. The tail rotor spins at more than 3,000 RPM and may be invisible to an untrained person. The rotors can generate winds of 60 to 80 miles an hour. If anybody's ever been at a landing zone when these things come in, it's windy and it's miserable. And I would encourage each and every one of you to not stand, you know, between the fire truck and the helicopter, but stand on the other side of the fire truck as much as you want to video record it and take pictures or whatever. It's safer for you. It's safer for the patient. Most times scratch that. We shouldn't have the patient out at the landing zone. They should be in our nice warm ambulance where we're giving them treatment and whatnot. So the only time we would be loading with the patient right there is, you know, if we're landing in a wilderness setting or something like that. Aside from that, we want them protected in the back of the ambulance and out of the elements the best we can. So setting up landing zones, the pilot usually lands and takes off into the wind. So just to note, like if you can track, if you're responsible for landing zone operations, you know, let them know where the wind's coming in and coming out of. Most civilian helicopters need a landing zone of 100 by 100. DART helicopter is a lot smaller. DART can actually land up on Mount Monadnock. There's an area up there that they can land. So pretty cool, but just again, it goes back to knowing what your local resources are and how much space they need to actually land their helicopters. So obviously, we also want to try to make sure the landing zone should be as flat as possible and free of debris. We don't want to put out cones or flares or anything like that because they can get sucked up in the rotor wash, and then that's a really bad day for everyone. So these are fixed lights here for the landing zone. They're not temporary structures. So just be mindful of that. We also don't want to shine lights or lasers or anything like that at the helicopter or whatever. We shut down our emergency lights and just focus on, you know, having the scene lights set up there to, you know, illuminate the area. So check for any nearby wires. If the site slopes or has any obstacles, we want to notify the pilot, and whoever's running the landing zone operations should be, you know, telling the pilot all this stuff. And there's an air to ground channel in our New Hampshire radio banks where you can flip over and talk to our different helicopter air medical transport partners, you know, give them a brief update of what's going on with the patient, as well as, you know, whoever's running the LZ, the landing zone, what some of these hazards are. Again, I talked about using flags, fuses, or flashing emergency lights and keeping vehicles clear of the landing zone. Very important. Anybody that's on a fire department or fire apparatus that are there, depending on the helicopter company that's coming in, they like to usually see some type of charged hose line that's already been laid out. God forbid there's a fire, or if there's a crash or something like that, it's good to be ready to go with the fire suppression stuff if need be. So loading patients into helicopters, we're not loading anybody into the helicopter until the flight crews come out and met us and agreed that, yes, they're going to take this patient and they're going to go to the helicopter. But some things to keep in mind: secure all loose clothing, sheets, and instruments. If you can use eye protection for you and eye protection for the patient, that's great. Typically, we're not doing what we call a hot load, where the helicopter's still spinning. Most of the time, they land the helicopter and they power it down completely, and then the flight crew will get out and come into the back of the ambulance, get a report, do anything that they want to do to stabilize the patient, and then do the transport or transfer over. Always approach the helicopter from the front and only after the pilot signals that it's safe. Again, most of the time with our air medical partners in New Hampshire, that's not a problem because they're powering down and getting out and coming over and talking to us. So loading patients into the helicopter, follow the helicopter crew's instructions, give the patient report to the crew, away from the noise, and offer your assistance. Again, most of the time they're powered down, so noise isn't a factor. And make sure you're working to properly package and secure them however they want to see the patient secured. So here's the summary for this chapter. So as an EMR, you need the proper equipment on an emergency call, including the medical equipment in your support kit, your personal safety equipment, and equipment to safeguard the accident scene. All very important. The 6 phases of an emergency call are preparation, dispatch, response, arrival, transferring the patient to other EMS personnel, and your post-run activities. And we talked through all of those earlier. So let's jump into our quick quiz here as we close out the night. Which of the following is not one of the phases of an EMR call? A, arrival at the scene; B, post-run activities; C, scheduling for upcoming shifts; or D, preparation. Awesome. I'm seeing C here, scheduling for upcoming shifts, and that is the correct answer. Question 2, information from dispatch should include all of the following except the A, number of patients; B, nature of the call; C, nearest hospital; and D, callback number. C, yeah. Typically dispatch has never given me that information. So you need to know what the hospitals are in your catchment area and what their capabilities are. So they don't give us that information. So you're absolutely right. Nearest hospital is not typically included. When approaching the helicopter, you should always approach from the rear, always approach from the front, attempt to move the patient to the aircraft as soon as it lands. Or D, you do not need eye protection. Good, smart crew. Always approach from the front. All right, folks, I have been asked to remind you that the quiz from week 1 closes tonight at 11:59. If you have not taken that quiz, or you've taken it once and not done as well as you wanted to do, you can take it again. What else do you want to know from me, Catherine?
So regarding the quiz, so is it going to take your highest, or will it only take the second if you were to take it a second time for your score?
I'll get you an answer on that right now. Hold on.
It takes the highest no matter which attempt it is.
It does. Okay, thank you.
Yeah.
All right, thank you.
So it would behoove you to take it twice. Only the highest score. David, go ahead. David, did you have a question? Can't hear you, sir. Sorry. Still no. Feel free to plug your question in the chat and I'll happily answer it. Other thoughts or questions, folks? Andrew, go ahead.
I'm not sure it's directly related to the class tonight, but as far as just transport and ambulances in general, as an EMR, have you seen like ambulance services kind of letting you like as an EMR kind of ride along and that sort of thing, even though that's not typically something I would do in my town?
Yeah, so actually the state changed the law a couple of years ago. All you need to run and transport an ambulance is one EMR and one other licensed provider. So that could be an EMT, advanced EMT, or paramedic. And if the call is totally within the scope of an EMR, then the EMR can actually tech it into the hospital themselves. So
awesome, thank you.
Great question, and that's something that we're seeing more of nowadays. Thank you. And folks, I did just confirm with Max that regarding both quizzes, they will only take your highest grade. So feel free to take the quiz twice and don't be concerned that you might get a lower score the second time because they're different questions. Good question. Catherine.
So it's not exactly having to do with this class per se, but do you know when or if they are going to have another EMT course coming up this year?
Yes, if you stay on, anybody that wants that information, I can, if you stay on, I can look it up on the state website for you.
Thank you.
Yep. So David, real quick, David asked about the storm, gauging whether or not we're going to have class on Saturday. What I said to the crew earlier, for anybody that missed it, they're going to have a determination by class on Friday night, whether or not we'll be hosting class on Saturday. Of course, use your discretion. Even if we have class and you start driving and it's unsafe and you don't feel like you're going to make it or be safe about it, then turn around and go home and we'll work something else out. So the short answer is you'll have an answer Friday night. Thanks. Sorry to cut you off. Somebody else was talking. Sorry.
Yeah, David, I had actually just looked up EMT classes before I got on the call. I was just going to make a comment if you.
Oh, yeah, please, Andrew.
So I checked the New Hampshire Fire Academy's website. There definitely are various other EMT classes happening this year, but I also checked the, I think it was NewHampshireCPR.com. They have some big classes coming up later in the year. I noticed a big, like a really large class in September at least. So there's that besides what's on the New Hampshire Fire Academy's website. So I'm not sure the standardization versus like what's on the Fire Academy's website versus like what all these other providers offer. But that's what I saw.
Yeah, no, thank you for that. And I just want to preface this conversation by saying, you know, obviously the state doesn't endorse one program over the other. The state currently does not run a state EMT course. We're really focusing our efforts on the EMR level right now. Eventually, we'd like to maybe see an EMT course at the state level or hosted by the New Hampshire Fire and EMS Academy. However, we're not there yet. The other thing we're trying to figure out right now is if we could do a bridge course between EMR for the folks that are certified in EMT. However, that's probably a couple years in development. So if you folks have a passion for this stuff or are excited to move on and move up, you're going to want to work through either your departments or find one of these other EMS, accredited EMS organizations that teaches like New Hampshire CPR, or, you know, there's a handful of other programs across the state. Again, we don't officially endorse one over the other. These are just, you know, we'll show you what the options are, and then you folks can make a decision based on that. Other thoughts or questions? Great questions, folks. All right. Did we hear back? I have to talk to Max about the affiliation, so we'll have an answer for you Friday night. on any of the unaffiliated folks. So, and the 3 unaffiliated folks I had was Anna Briggs, Christopher R, and was it Daniel Ellingwood? Was there anyone else that got a call about being unaffiliated? All right, folks, I'm gonna. Oh, go ahead, Chris.
Oh yeah, my bad. Do you still are you going to handle that, or do you think we need to like try to reach back out to the academy on that behalf? I mean,
if you want to reach out between now and Friday, feel free to do so. Otherwise, I'm going to talk to Max and see what he has to say about that portion of it prior to Friday's class. What I'll say is keep doing your homework and keep coming to class because you folks are here and you're working towards it. So,
all right.
Yeah, that I was gonna ask that if we should still keep coming to class because they had implied today that we wouldn't be able to take the course if we weren't affiliated. So, or else have to pay for it. So I just kind of want to be sure.
Yeah, no, you're here now, and I'll express the urgency to Max, and we'll try to get in touch with you folks tomorrow if we can. If not, by Friday night.
Okay, great. I appreciate it.
Thank you, folks. So I'm going to hang out for a little while. If you folks have any questions, I'm looking up the EMT courses coming up as well. And aside from that, folks, you've been a pleasure. I will be back Wednesday night. I'm also going up to Walpole on Saturday as long as we have class. So sorry to the Concord crew. You won't have to see me again, at least Saturday. Aside from that, good luck on your quizzes if you haven't done it, and I'll be in touch with you in the near future.
Thanks, sir.
Yep. Thank you, folks.
Wait, hold on. It's not even 10 yet.
I'm not, well, we'll call it 10. Does that work for you?
I guess. I was
All
like,
right.
wait, what is he doing?
Because you answered my questions and you were involved, we got out of here a lot quicker. It makes a difference.
Nice.
All right. Anybody that wants to hang out and talk to me about whatever, feel free to do so. And aside from that, you're free to leave.
Hey, David, I had a question for you.
Yeah, fire away.
So the EMR bag for responding to calls, because that sounds like something I'm going to have to end up putting together since the ambulance service, I'm associated with the fire department, not the ambulance service in the area. Would you think it's a better idea to try to piece one together rather than trying to get, I don't know if there are bags out there that are already put together, or I don't know, what's your thought on just the topic in general?
Can I?
Yeah, please go ahead.
So regarding that question, I know on Amazon, because I had the same question, you can actually find a complete put together bag, and it's like maybe 130, I believe, but it's not super expensive, but it has your protective gear. It has the face masks and a bunch of other necessary tools that you may or may not need.
Yep. So I would try to get a kit. Like over time, you're going to figure out what supplies and equipment work better for you or what you like to use. So like I bought a 511 backpack and just outfit it with what I wanted from a supply and equipment standpoint. So part of it's personal preference. If you folks are just, getting out there and rocking and rolling for the first time and trying to figure out what you like and don't like, then buying one of those canned or pre-packaged kits isn't necessarily a bad thing. But I'd also encourage you folks to look at and work through your departments to see what they can provide you with from an equipment and supply standpoint, because you folks could spend a fortune on buying that stuff. So don't do that. Don't spend a fortune on it. Work through, or maybe your department will reimburse you.
Oh, awesome. Okay, I appreciate it. Thanks, folks.
Yeah, no worries. So, folks, I put the link for the upcoming, and it looked like somebody else did as well, the EMT courses held in New Hampshire. What I'll say to you folks as well is I know for a fact Mass and Vermont are NREMT states now that are part of the National Registry for EMTs. I believe Maine is as well. So if you live on one of the borders of those states, there might also be state options for you to, to go take the course over there. Just note that you might have to do a couple of New Hampshire specific trainings, what they call the scope of practice module, prior to getting licensed in the state of New Hampshire. So, but I'll just share my screen real quick. If you follow that website, you can see all the courses that are listed here. Looks like there's some in Epping, Waterville Valley, Nashua. I'm not promoting any one service or department over the others, but I will say some private EMS organizations are actually paying you to go to EMT school and giving you a job to work on the ambulance so that you get experience. Your school is paid for by them, and they're getting staff out of it. So take a look at those opportunities as well if that's something you're interested in, because I really wish I had gotten paid to go to EMT school. But anyway,
so with that, say if your department, they're not all up to date on upcoming courses, would you just bring it to their attention and be like, hey, there's an EMT class?
Yeah, I think that's a great question, Catherine. If it were me, I would, I'd be a rock star in this course. Not to say that you haven't been, but I would, do my best to get as high a grade as possible here. I'd do my best to get certified and licensed as quickly as possible when you finish this, and start having the conversation with them so that they can see that you're operating at that higher level, and your thirst for knowledge is there, so that if they invest in you, you can hopefully give them something back as well. So yeah, having a conversation with them, finding a class that works for you, those are all options as well.
Okay.
Other thoughts or things folks want to talk about? Dave, go ahead. Oh, I see a paper being held up. I can't see what it says though. Chat. Something about chat. Can anybody read that? Dave, I'm just going to put my cell phone number in the chat if that's okay, and you guys can call me. Does that work? Can't see that. So give me a call when we wrap up here. Oh, wait, that's my old number. Use this one. Sorry. Nick, go ahead.
I just wanted to let you know the big blue button company has actually disabled the webcam sharing due to students discriminating against other students via Google search. So we cannot see each other. We can just see the instructors.
Oh, I did not know that. Thank you. Really? That's fascinating. Okay.
Trying to find out and looking through my settings and trying to turn on everything that I could, it still doesn't work. But if you Google search it, it basically says that it will not turn the system on.
Okay. I don't think Max was aware of that, so I'm gonna make him aware of that. Any other thoughts or questions? Your status, make presenter unlock. What happens if I unlock? Wait a minute here. Well, I have you folks. I'm just going to do a test. Let's see, Nick. What happens if I unlock you? Nick, did that do anything to your screen?
Yes, actually, I can see David, Melissa, Kat. So it's turning on people.
Oh, so okay. So I don't know if this violates our policy or whatever, but Melissa, can I turn your webcam or share your unlock Melissa? Okay, cool.
There's everybody.
And let me see.
All I see is.
Yep, hold on, Catherine. I'll unlock you now. This is good. All right, we're getting there.
Let's see. How do you turn the camera on?
Oh, I hear you, David.
Who, David?
Yeah.
Okay.
Hi. Well, I hear
Okay.
Sophie.
I logged in through Sophie's thing on the phone.
Nice.
I guess she has also an affiliation issue also.
Ah, okay. Thank you. Sorry about that. Sophie, all right.
Oh, I see Catherine now and Melissa.
Yeah, I'm adding. Okay. I didn't know that that was a thing. So my apologies, folks.
Yeah, because she got a voicemail saying affiliation or she's going to get charged for the course, but the course
Yep.
is free.
We will address that and get back to you folks.
But I can also check with Raymond Ambulance because I think she was planning to work for them maybe when she turns 18.
I would encourage you to do that sooner than later.
Okay, so I'll check with them tomorrow when she's in school.
Yep. Yeah, I would go that route. That's probably going to be the path of least resistance for that.
Okay.
So cool. Anything else?
Any other questions?
All right. Folks, I'm going to keep hanging out. Otherwise, feel free to drop. Sorry about the webcam thing. I didn't know that was a thing. So what'll be interesting next time, and can you let Max know? Well, I'll try to remember to let him know, but on Friday night to see if you folks can see other people as well, or if we need to go through each time and actually do this, like if we've unlocked you for the entire course, or if this needs to be a recurring thing. So awesome. All right. Well, good night, everyone. Thanks for your participation. And William, are you still on? I know you wanted to catch up here. Oh, hold on here. I'm still.